Have any opening remarks?
I'm good.
Good? Okay, we'll get right into our agenda. First, we have Nicole Livanos, and she is going to do an overview of advanced practice nursing and full practice authority. Thank you, Ms. Livanos, for being here. We appreciate you.
All right. Co-chairs Krawick and Lambeth and members of the committee, thank you so much for having me here today. My name is Nicole Livanos. I'm the Associate Director of Legislative Affairs for the National Council of State Boards of Nursing. We are a regulatory organization, and our members include nursing regulatory bodies across the country. We're dedicated to promoting excellence in nursing regulation. I'm going to use this PowerPoint that you see to guide my presentation today. All right, so a quick overview of what I will cover. First, an introduction to APRNs and the APRN consensus model. Next, we'll move to the regulatory framework for APRNs across the country. I'll turn to the state of the states, focusing on recent full practice authority efforts as well as actions taken during the COVID-19 pandemic by over a dozen states. And last but most important, how the evidence shows us that removing barriers results in safe APRN care for patients. So the APRN consensus model, of which NCSBN is an author, was adopted in 2008, and it sets standards for licensure, certification, accreditation, education, and practice of advanced practice registered nurses. The model is evidence-based and patient safety focused. The national model has 7 elements. That's title, role, licensure, education, certification, independent practice, and independent prescribing. Each element is important to protecting the public, for closing the information asymmetry gap for patients who are increasingly mobile and may come to North Carolina from other states for their care, or may access care through telehealth from a provider located here or located outside of the state. APRN is the umbrella title for 4 APRN roles: certified nurse practitioners, clinical nurse specialists, certified nurse midwives, and certified registered nurse anesthetists. APRNs are first and foremost registered nurses. They're licensed RNs who obtain graduate level or doctoral level education to become APRNs. APRN education programs are narrowly tailored to the APRN role. And for nurse practitioners and clinical nurse specialists, they're further narrowly tailored to a specific population foci the APRN enters the program for. So to give you an example of how this works, graduate NP program, so as you know, many North Carolinians rely on psych mental health nurse practitioners. In order to become a psych mental health nurse practitioner, a registered nurse would enter into a graduate level program in a role, nurse practitioner, and a population, psych mental health. Graduate NP programs first extensively cover the fundamentals. That includes advanced pharmacology, advanced physiology, advanced physical assessment, before then narrowing to that psych mental health, in this example, population focus. After graduation, that APRN would sit for a national certification exam, again tailored to their role, nurse practitioner, and population focus, psych mental health. Once they pass, they obtain national certification, and then they maintain that certification throughout their licensure. The full practice authority provisions of the model, independent practice and independent prescribing, are a major component of the SAVE Act and our conversations here today. The model calls for APRNs to practice to the full extent of their education and certification. And the ability for APRNs to practice and prescribe to that full extent is demonstrated by decades of evidence prior to the APRN consensus model being adopted, and has proven true and stood the test of time since the adoption in 2008. APRNs are safe and quality care providers. Uniformity in APRN regulation and practice is a goal of the model. It's critical for patient understanding of their healthcare providers and is necessary for, again, that growing borderless and more mobile healthcare environment. By focusing on only these elements necessary for APRN care, the model avoids the burden and risks associated with unnecessary regulation. So within the model, boards of nursing are the historical and appropriate regulators of APRNs. boards of nursing across the country regulate nurses of all educational preparation, from licensed practical nurses to registered nurses to, of course, APRNs. In addition to licensure of APRNs and enforcement of the Nurse Practice Act, Board of Nursing members and staff are experts in regulating APRN practice, APRN education, and certification to ensure patient safety. In all states that have modernized their APRN statutes to remove these restrictive requirements, APRNs are regulated appropriately by boards of nursing. It's under that framework that we have evidence of quality outcomes and safe care. In only 3 states, Alabama, North Carolina, and Virginia, APRNs are jointly regulated by the Board of Nursing and the Board of Medicine. These structures are outdated and they're inappropriate. The Federal Trade Commission has warned lawmakers in multiple states that physician regulation of APRNs is inherently biased, stifles innovation, and suppresses competition in the healthcare marketplace. So next I want to turn to the state of the states. So currently, over half of the states have removed these barriers for 1 or more APRN role. 24 states, the District of Columbia, and Guam have removed barriers for nurse practitioners, and that's a number that grew by 2 in the 2021 legislative session, when both Delaware and Massachusetts enacted full practice authority. APRNs with full practice authority are actually practicing in North Carolina today. So APRNs practicing without these barriers today. That includes within the Veterans Health Administration, for nurse practitioners, clinical nurse specialists, and certified nurse midwives, and CRNA policy changes on the horizon. On North Carolina's military bases, and within the military across the country, APRNs practice without these barriers. And in Indian Health Services as well. That's full practice authority occurring today in North Carolina. The COVID-19 pandemic saw both state and federal action to reduce and remove barriers to APRN care. 12 states took emergency action, whether it be through executive order or legislation, to remove collaborative agreements for APRNs during COVID-19. So that's 12 restrictive states that otherwise had collaborative agreement structures, saw it necessary to immediately waive these requirements in order to mobilize APRNs to provide needed care during the pandemic. These 12 so-called experiments were on the books ranging from a few months to now over 2 years. The state saw safe practice continue seamlessly after waiving these barriers. And Massachusetts was the first state to make those waivers permanent, enacting full practice authority in the state. At the federal level, the Trump administration called for removal of collaborative practice agreements in March of 2020, so right at the beginning of the pandemic. Each governor was sent a letter by HHS secretary calling for waivers of requirements, including, quote, any requirements for written supervision or collaboration agreements in order to avoid significant delays in provision of services. We also saw CMS take action. CMS waived a rule that requires supervision of CRNAs during the COVID-19 pandemic, and Arizona's Governor Ducey permanently opted out of that CMS rule, just as 17 other states have done, in order to increase access to care in rural areas. The VHA also expanded their full practice authority to include CRNAs during the pandemic, and as I mentioned, those efforts to make that policy permanent are ongoing. All these actions were taken so that APRNs could safely provide needed care to practitioners during the COVID-19 crisis. And although North Carolina did not join the 12 states to completely waive these requirements and has not yet joined the 24 states permanently removing these barriers, with an abundance of evidence, we don't have to assume or guess what is going to occur with this policy change. We have examples from many states to show us how the effects of this policy change would go. So the next several slides are going to have examples and citations from the research that focus on access to care, patient outcomes, removing regulatory barriers, and safe care from APRNs. I'll highlight a few as we move through. So first we can look at access to care by looking at the state data. So data from states that have removed barriers help to illustrate the potential benefits that North Carolina could see from this policy change. After removing barriers in Arizona, they saw an increase in nurse practitioners in urban, and rural counties, with the largest increase happening in those most rural counties. In Nevada, they saw a 33.4% growth in practicing APRNs, and the top growth was seen in the top 3 rural counties. Lastly, North Dakota saw an 83% increase in licensed APRNs in the 6 years following the policy change, which, as you can imagine, had a significant impact on access to care in that very rural state. According to 2022 HRSA data, 96 of 100 of North Carolina's counties are partial or full mental health professional shortage areas, and 91 of those counties are whole county shortage areas for mental health professionals. Psych mental health nurse practitioners and clinical nurse specialists can help fill the gaps. Studies have shown that collaboration among psych mental health providers has been found to be most successful when the parties agreed to collaborate, shared clinical interests, and perceived mutual benefit from the collaboration. It makes sense intuitively. Collaboration founded in agreement and for the patient's needs, rather than a mandate, leads to success. Most importantly, the research demonstrates that these providers in the psych mental health space can make a significant contribution to behavioral health. So as it's in the committee's name, I want to highlight some data surrounding APRNs caring for Medicaid patients. The Medical Care Research and Review Journal found that a significantly higher percentage of practices with nurse practitioners accepted Medicaid compared to practices without nurse practitioners. The Mercatus Center recommended for states interested in reducing the cost of care for citizens on Medicaid to consider relaxing restrictions on both nurse practitioners and physician assistants. Next, we'll look to rural care more generally. In 2019, 70 of 100 of North Carolina's counties were considered rural. And we know that patients in rural areas of the state already rely on APRN care. HRSA data again demonstrates there are 7 APRNs per 10,000 North Carolinians in rural areas. Comparatively, there are 5 primary care physicians per 10,000 in non-metro or rural counties. That's 7 to 5. Evidence from other states shows us that the impact that APRNs have today on North Carolina rural health can only strengthen by removing these barriers. A study in the Journal of Nursing Regulation finds NP supply grew in both rural and health provider shortage areas, counties, regardless of these barriers. So we know APRNs practice in rural areas, but the supply was higher in those states with full practice authority. And for treatment of those with substance use disorders, research found that removing barriers for APRNs increased availability of medication-assisted treatment, especially in rural areas. Turning to maternal health outcomes, I know my colleague will be addressing the expert care provided by certified nurse midwives in her presentation, but I want to highlight that the evidence here is overwhelming that birth outcomes are improved with certified nurse midwife care, and that CNMs and women's health nurse practitioners are key to improving maternal care across the country. Transitioning away from access to care to highlighting the substantial evidence on the benefits of APRNs increasing access to care, I'll highlight the call for and support for reducing unnecessary regulations by removing these barriers. The Cato Institute ranks states in their freedom levels. In the 2021 report, North Carolina was lacking on their scoring for occupational freedom, quote, especially for the health professions. One of the criteria that Cato uses is Nurse Practitioner Independence Index. The Federal Trade Commission, in their extensive involvement in this issue, found that removing barriers leads to greater supply, and in underserved areas and populations, what this means is that consumers gain access to services otherwise unavailable to them, And in well-served areas, supply expansion may lead to lower prices and drive down healthcare costs. So it's a win in both rural and non-rural areas. In their 2014 policy perspective, the FTC concluded, after extensive evidence demonstrates that APRNs are safe and that restrictions on APRNs, to the extent that they should be there, should be no greater than the public protection mandate. And that's something certainly regulators can get behind. Last but most important, removing barriers does not impact the provision of safe and quality APRN care. The National Governors Association, in their policy paper on APRN full practice authority, found no studies that raised concerns about the quality of care provided by NPs. For certified registered nurse anesthetists, a study out of RTI International here in North Carolina concluded that anesthesia care is equally safe whether provided by a CRNA working solo, an anesthesiologist working solo, or both of the practitioners working together. For nurse midwives, the American College of Obstetricians and Gynecologists, ACOG, notes that the highest quality and seamless care provision should include CNMs and OBGYNs having access to a system that fosters collaboration among licensed and independent providers. And lastly, the Campaign for Action highlights clinical nurse specialists as, quote, a force for improving safety, outcomes, and healthcare delivery, which is, of course, quite the accolade. So I want to end my presentation with some key takeaways, a summary of the information that I provided today. So first, APRNs are educated and certified to provide care within their role in population, within their lane. They are expertly regulated by boards of nursing across the country, which are the appropriate regulators of this profession. Over half of the states have removed barriers for one or more APRN role. Should I keep going? Okay. Yeah, is that the timer? It's aggressive. There are APRNs with full practice authority practicing in North Carolina today, again, within the VA system, within Indian Health Services, today, practicing in North Carolina. And we know that removing barriers will increase access to care. It'll reduce unnecessary regulation. And most importantly, from the regulatory perspective, it'll maintain public safety. The policy change discussed here in the language of the SAVE Act is a common sense advancement that's been proven in 24 other states. So we don't need to guess what will happen when the SAVE Act becomes law. We have evidence from countless states that access to care will increase, that unnecessary regulations will be eliminated, and that APRN care will remain safe and produce quality outcomes for patients. And that's it. Thank you so much, and I'm happy to take some questions.
Thank you, Ms. Livanos. Great information. Questions from the committee members? Representative Baker.
Thank you, Madam Chair, and thank you so much for the presentation. I had a couple follow-up questions. When you talk about access to care with Arizona, which was an important study, I would definitely agree. And I noticed that you quote a 77% increase in rural counties with nurse practitioners going there. That data came out in 2007. Are you familiar with the data that came out in 2014?
I'm not.
So that is the Arizona data, and they followed up from that. So as I'm sure you know, Arizona got rid of their restrictions as you described in 2002, and the data you have here is from 2007. But they continued collecting the data, and in 2014 they built on that, and they reported that urban areas saw an increase in the number of NPs by 31%. Rural areas, isolated rural areas, had a decrease of nurse practitioners of 11%. So when you actually follow out their data, the data does not support that the nurse practitioners go to rural areas. And of course, there's a lot of data in that regard too. So I just think it's important that we realize that that is not the representative data from Arizona. So I wanted to make sure we were aware of that.
Follow up?
Follow up? And then my follow-up, wanted to ask you, when you noted that there are decades of evidence demonstrating safe and quality care providers, I wondered if you were referencing the Cochrane reviews or what in particular you were referencing with that.
Yeah, I mean, in addition to the Cochrane reviews, there's decades, again, of evidence that have been tracking APRN-provided care, their impact on outcomes of care for all of the 4 roles. So I'm not referencing a specific study, but I would be happy to provide you with some of the evidence that we have.
I think that would be great because in my review of the literature, the Cochrane study is really the only comprehensive one, and those studies looked only at nurse practitioners in primary care areas. And of those studies, of over 8,000, close to 9,000 studies, only 18 were considered standard peer-reviewed studies, and only 3 of those were in the United States. And of those 3, only 1 is really worth even discussing in this regard. So I'd be very interested to know what the other studies are.
Yes.
And then one more follow-up.
Follow-up.
Thank you for your patience. And
Yeah,
thank you for
absolutely.
the questions. And I, as a psychiatrist, I'm very concerned, like you are, with the provision of mental health in all areas and in the rural areas. And I noted the collaborative indicators that you mentioned, which I strongly support collaboration. But I did think it was very interesting, and I think that is an important part of the training of nurses, that it is very tailored, as you mentioned. Mm-hmm. And it just strikes me that that's very different than my training. My training, as a physician, is intentionally broad so that I know what I don't know, so that even though I'm seeing somebody for mental health care, I'm also considering what other issues or medical diagnoses they might have, so that I am broadly trained to make sure I know that, gosh, I should be considering something else. So I find that, they are different models, but I do think collaboration is where we benefit the best from that. So I appreciated that slide. So thank you.
Thank you.
Any other questions? Senator Corbin.
Thank you, Madam Chair. So when we're talking about barriers, I think one of the things we're talking about is a physician supervising these folks. Is that accurate?
Yes.
So in my district, I've got 2 counties, and I'd love for any of you to look them up, Graham and Clay County. And Graham and Clay, 1, do not have a hospital. Number 2, do not have doctors. I think Graham's got 1. So access to care for my folks in those counties means going to a clinic, urgent care center, or going to another county. So I'm very interested in the subject because my district is very rural, and we're talking about access to care that does affect my folks a lot. Thank you. Comment.
Representative Farkas.
Thank you, Madam Chair, and thank you for your presentation. Just a quick question. You've talked a lot about, or you mentioned a number of states have gone ahead and passed legislation that's like the SAVE Act. Mm-hmm. Have any of those states, with it now in the rearview mirror, have any of them repealed that legislation, or have you seen action that kind of steps away or tries to restore those barriers?
Ms.
No.
Lavanos.
Oh, thank you so much. Thank you for your question. And no, I'm not aware of any state that has reversed course, either with full practice authority legislation like the SAVE Act or with the CMS rule opt-out for CRNA supervision.
Thank you. Any further questions from the committee? Seeing none, thank you, Ms. Lavanos. We appreciate your presentation. Next, we have the case for physician supervision for certified registered nurse anesthetists, and we will recognize Dr. McNeil Cronin. Full disclosure, Dr. Cronin is a good friend. He's put me to sleep a few times.
Thank you, Senator Krovic. Thank you, Representative Lambeth. Thank you, committee members. It's an honor to be here to speak before you today. My name is McNeil Cronin, and I'm an anesthesiologist with Piedmont Triad Anesthesia in Winston-Salem, North Carolina. And today I have the privilege of speaking to you in my capacity as the president of the North Carolina Society of Anesthesiologists. I will try not to put anyone to sleep today. A little background on me: I'm an all North Carolina trained physician. I received my medical degree from Wake Forest University School of Medicine. I then went to the University of North Carolina, Chapel Hill to complete my internship, and I returned to Winston-Salem to complete my anesthesia residency at Wake Forest University Baptist Health. Thank you for allowing me to speak on such an important topic. Before I begin, I want to tell you a personal story about the day that I decided I would become an anesthesiologist. I was a third-year medical student at Wake Forest University, and I was on my anesthesia rotation. And for those of you that don't know, your third and your fourth year of medical school is spent completing a variety of different rotations in all areas of medicine. So I was in my third year, I was in my anesthesia rotation, and I was in the operating room in a neurosurgery case. The patient had been diagnosed with a brain aneurysm that had not ruptured, and the purpose of this case was for the neurosurgeon to clip that aneurysm to keep it from rupturing. We're about halfway through the case, the patient's doing well, everything is stable, and prior to that aneurysm being clipped, and without warning, in an instant, that aneurysm ruptured. Arterial blood began to pulsate into the brain, the patient's heart rate spiked, their blood pressure plummeted, and a general panic set over the room. I knew as a medical student in that instant that this patient's life was in danger. The one person in the room that was completely calm and in control was my attending anesthesiologist. He lowered his voice, he slowed his cadence, and he began to give precise, specific instructions to the care team. Go to the blood bank and get 4 units of packed red blood cells. Get 2 more large bore IVs. Give these 3 specific resuscitative medicines in these doses and in this order. He was in complete control of the room. Slowly but surely, his calm, controlled, knowledgeable leadership began to seep into the room, and the patient began to stabilize. The surgeon was able to successfully clip the aneurysm, and the anesthesia team was able to successfully and safely transport that patient from the operating room to the recovery room. After the case, I asked my attending anesthesiologist, how were you able to stay so calm in such a crisis? His answer was, that is the job. That is what we are trained to do. I knew in that moment that what I wanted to do with my life was to become an anesthesiologist, to set about on a journey to receive the best education, the best training, the most knowledge that I possibly could so that when and if I was ever faced with a similar crisis, I could respond in the same calm, controlled, knowledgeable way that my attending anesthesiologist did, that on that day saved that patient's life. So that day brings me to this day, where I have the opportunity to speak before you all on the many, many benefits of physician-led anesthesia care. Let's get started. So today I will tell you that the physician-led anesthesia care team is the best way to promote patient safety and high-quality care. I'll tell you that physician anesthesiologists are uniquely educated and trained for critical moments in healthcare, when seconds count and decisions over diagnoses and treatment can be the difference between life and death. I'll tell you that eliminating the physician supervision requirement for nurse anesthetists would have no impact on access to care. And I'll tell you that with patient safety in mind, and aware there is no recognizable benefit of removing the physician supervision requirement, maintaining that requirement is the best policy option for North Carolina, and it's consistent with decades of state law. So let's talk a little bit about the anesthesia care team. The anesthesia care team involves the delegation and monitoring of appropriate tasks by the physician to non-physician anesthetist, including nurse anesthetist and anesthesiologist assistants. Based on their medical education and training, physician anesthesiologists are uniquely qualified to lead the anesthesia care team in this way. Nurse anesthetist and anesthesiologist assistants are valued and important members of the anesthesia care team. And when physician anesthesiologists and anesthetists work together as a team, patients receive safe, high-quality anesthesia care. The anesthesia care team is by far the most common mode of anesthesia delivery in the state of North Carolina, and it's the model in which I work every single day. Let me tell you a little bit more about the way that this works. The physician will evaluate the patient preoperatively and conduct a thorough history and physical. We'll identify any and all medical diagnoses with regard to the patient's brain, their heart, their lungs, their endocrine and musculoskeletal systems. and will order and evaluate the patient's appropriate preoperative testing and lab results. Once that comprehensive process has taken place, we'll prescribe an individualized, specific anesthetic plan for that patient, ensuring all possible risk is mitigated. Once the anesthetic has begun, it's not just emergencies that we treat. More commonly, we are treating minor course corrections, continuously optimizing variations in patients' oxygen saturations, their airway management, their heart rate and blood pressure variability. All of these measures meant to prevent emergencies and keep the patient heading down the track of a safe and high-quality anesthetic. This is why, when working together, the anesthesia care team is so valuable. Physician anesthesiologists are guardians of public safety, uniquely educated and trained for the critical moments in healthcare, in the operating room, in the delivery room, in the intensive care unit, and in a crisis. It's important to note that we are physicians first, and that giving the anesthetic is just one component of our job. Physicians lead care with regard to preoperative evaluation, preoperative patient optimization related to the patient's specific medical history and medication regimen, appropriate preoperative testing, appropriate facility selection, and when necessary, appropriate case cancellation. Sometimes the greatest benefit to patient safety is making the difficult decision that a patient is not yet ready for a scheduled surgery. As I mentioned before, based on all of this information, the physician will then prescribe a precise, individualized anesthetic for each patient. This anesthetic plan revolves around the risks and benefits of specific anesthetic drugs in specific doses, the risks and benefits of various airway management choices, the risks and benefits of regional anesthetic choices, such as a spinal anesthetic or a nerve block. During the anesthetic, we are directly and physically present for all critical parts of the case, and we are always immediately available for any medical issues that might arise, big or small. Our supervision is direct and it is in person. Once the surgery is complete, our care continues into the recovery room, diagnosing and treating any and all potential complications. We are the first contact with the patient preoperatively, and we supervise their care all the way to making the decision for either discharge home or admission to the hospital. You see, the supervising physician directs and manages the patient's medical conditions before, during, and after surgery. You cannot remove all of the important preoperative work and all of the important postoperative work of the physician and still maintain the same safe, high-quality intraoperative anesthetic. All of these components are interconnected, and they all matter. As medical doctors, physician anesthesiologists specialize in anesthesia care, in pain management, critical care medicine, bringing the knowledge required to treat the entire body. This education and training provides physician anesthesiologists the unparalleled ability to lead care teams and navigate life and death moments in patient care. Surgery and anesthesia are inherently dangerous. Anesthesia is different. Once that preoperative evaluation has taken place, the physician will prescribe the specific anesthetic plan, which can be a spinal anesthetic, a regional anesthetic, but most commonly it is a general anesthetic. And what a general anesthetic entails is intentionally putting patients into medically induced comas, taking over complete control of cardiovascular and pulmonary systems, intentionally paralyzing patients to help facilitate with the procedure, leaving them unable to breathe, placing breathing tubes in patients' tracheas, and placing patients on ventilators. With any provision of anesthesia, the patient is in an extremely vulnerable state, and emergencies can and do happen, and they happen everywhere, in any type of facility, and even with the best available safety precautions in place. Diagnoses and treatment regimens often must be decided accurately and in seconds. And with anesthesia, the diagnoses we are dealing with are things like cardiac arrhythmias, respiratory distress, hypoxia or dangerously low oxygen levels, heart attacks, strokes, pulmonary emboli or blood clots to the lungs, adverse drug reactions, and many, many more. And if any of these are diagnosed inaccurately, it can result in life-threatening complications. Removing the extensively trained and extensively knowledgeable physician anesthesiologist from an operation would only increase the risk of an emergency or an unfortunate event. And it's true that intraoperative deaths or deaths in the operating room have become rare, but you only have to widen that snapshot just a little bit to see that anesthesia remains inherently dangerous. Multiple studies have shown that 30-day mortality after an anesthetic is between 1.3 and 2%. Based on these studies, if 30-day mortality following an anesthetic were its own CDC category, it would be one of the leading causes of death in the country. When considering all of this, one would think that anesthesia would be the last place that you'd want to voluntarily remove the physician. Because of these dangers, education and training matter. Physician anesthesiologist education and training is different than nurse anesthetist. If I point your attention to this chart, when it comes to education, physician anesthesiologists receive up to 14 years total of education. When it comes to clinical training, physician anesthesiologists receive 12,000 to 16,000 hours of clinical training. The training is not the same. This education and training prepares the physician anesthesiologist to make critical decisions during surgery for any patient and in any situation. And in a field like anesthesia that I've described as so acute and so fragile, requiring accurate diagnoses and treatment regimens, increased education and training leads to increased diagnostic accuracy, and it leads to high-quality care. So what has North Carolina law said on this issue? Given the inherent dangers in anesthesia, North Carolina law requires a physician, either a physician anesthesiologist or the physician performing the procedure, to supervise a nurse anesthetist providing care. Under the anesthesia care team model used in most hospitals and ambulatory surgical centers, the overall responsibility for the patient's care and safety rests with the physician anesthesiologist. As recently as 2005, the North Carolina Court of Appeals declared that physician supervision of nurse anesthetist is, quote, a fundamental patient safety standard required by North Carolina law, end quote. And this is not just the standard in North Carolina. In 2018, the World Health Organization stated that anesthesia is complex and hazardous, and, quote, requires a high level of expertise in medical diagnosis, pharmacology, physiology, and anatomy. Therefore, anesthesiology is a medical practice. They concluded that whenever it is possible, anesthesia should always be provided, led, or overseen by an anesthesiologist. Physician-led care protects patient safety. Physician anesthesiologists' experience in preventing patient complications and responding to emergencies in surgery protects patient safety and can be the difference between life and death. I want to point your attention to two studies and take special note that these are both independently funded studies. The first concluded that the presence of a physician anesthesiologist prevented 6.9 deaths per 1,000 patients in which an anesthesia-related or surgical complication occurred. The second study, again independently funded, concluded that the odds of admission to the hospital or death were 80% higher when a nurse anesthetist provided care rather than a physician anesthesiologist. This was according to a national survey of more than 2.4 million outpatient surgeries. You can see why, when it comes to anesthesia, North Carolina law has consistently required physician supervision of nurse anesthetists. Removing North Carolina's requirement for physician supervision of nurse anesthetists would have no impact on access to care. That's because anesthesia is unique in that it is always provided as part of a surgical procedure, and a physician, either a physician anesthesiologist or the surgeon, is always directly involved in that episode of patient care. When considering Medicaid expansion, North Carolina should avoid jeopardizing patient safety by effectively creating a two-tiered system of care. One tier that includes physician supervision and one that does not. Maintaining the state's longstanding physician supervision requirement ensures we may continue to bring that value to every North Carolinian everywhere in the state. Just yesterday, the Old North State Medical Society called on the General Assembly to pass Medicaid expansion legislation, but without eliminating the requirement of physician supervision and compromising physician-led care. Let's talk about the impact on cost of care. Eliminating the physician anesthesiologist can actually cost more, as other physicians may be needed to consult or provide the services that a physician anesthesiologist does today. Things like assessing pre-existing conditions or handling emergencies and other medical issues before, during, and after medical procedures. According to an analysis of the nationwide inpatient sample data that compared surgical costs, when nurses led anesthesia care, surgical costs were 8.7% higher. According to a review article published in the New England Journal of Medicine, anesthesiologist-led care significantly reduced costs compared to the nurse model. Medically related surgical cancellations reduced by 88%, medical consultations reduced by 75%, and costs of laboratory tests reduced by 59%. These studies illustrate the tremendous value physician anesthesiologists bring to the perioperative process, both in terms of patient safety and efficiency, which impacts costs. Patient safety and costs are connected in this respect, and physician-led care both protects patient safety and reduces costs for North Carolinians. Because of everything I've told you today, North Carolinians overwhelmingly support physician-led care in anesthesia. According to a 2017 survey of North Carolina voters, 90% want a doctor to respond to a medical complication or anesthesia emergency during surgery. 90% also believe it is important that a doctor supervise a nurse anesthetist who is administering anesthesia or responding to anesthesia emergencies during surgery. Physician supervision has strong bipartisan support across the state, in rural North Carolina, in urban North Carolina, and among Republicans, Democrats, and unaffiliated voters. The data about patient safety and the data about public opinion in North Carolina both support the notion that there is value in physician-led care when it comes to anesthesia. So in conclusion, the physician-led anesthesia care team model is a proven method of delivering safe, high-quality anesthesia care. Physician anesthesiologists are uniquely educated and trained to lead, to diagnose, and to treat patients in any situation. They are irreplaceable and can be the difference between life and death. Given the inherent dangers in anesthesia, North Carolina law has long required physician supervision of nurse anesthetists. Eliminating the physician supervision requirement would jeopardize patient safety and have no impact on access to care, while creating inconsistent standards of care in our state. And in closing, protecting the physician supervision requirement remains the best policy decision for North Carolina to ensure that all of us, our families, and our constituents continue to receive safe, high-quality care when it is needed the most. Thank you again for allowing me to speak today, and I also would be happy to answer any questions.
Thank you, Dr. Cronin. Questions from the members? Senator Heiss.
Thank you, Madam Chairman. One of the things I kind of want to point out, in asking the question, but it also is quite confusing back and forth to what you're presenting. When you're talking about a physician-led care team versus talking about a physician anesthesiologist, when the facts and figures go up and say that a procedure done by a physician anesthesiologist has higher percentages than others, most procedures in North Carolina do not involve an anesthesiologist in any process. And so I'm trying to get to when we're comparing what is happening in this procedure with what happens in the specialized procedures of a anesthesiologist is involved in. But most are done by a nurse anesthetist under some supervision, generally by a surgeon, not a specialist in anesthesia. Is that not correct?
Well, it is correct that there are some procedures that the physician surgeon is the supervising physician. I don't believe that it's correct that it's most. According to payment models, medical direction of an anesthesiologist accounts for about 90% of anesthetics in this state. So I do believe that it's a minority of cases that involves that physician surgeon.
Senator Heiss, follow up.
Yeah. But medical direction goes back to the physician, not to specifically. For example, I have 2 hospitals in my current district that do not have an anesthesiologist on staff. It's not part of their model in any way, and everything done at that hospital is done by this physician and the nurse anesthetist.
It is correct that there is not an anesthesiologist at every one of these procedures across the state. I think that the law in its current form with physician supervision does ensure medical responsibility of that patient to the physician that is in the room, that is directly there, and that physician has training in medical diagnoses and emergencies, that broad training that I think adds, that supervision still adds to the patient safety.
Follow up?
And to ask this, do you have any sense, say over the last 10 years, as to the number of anesthesiologists in the state and their ability to cover the procedure compared to surgical procedures within the state?
Cronin.
I know there's about 1,500 anesthesiologists in the state. Their ability to cover what percentage of procedures they cover, I'm not aware of those statistics.
So, and
Follow up.
I guess the last question I want to get to that kind of at the core of this particular matter, but several others, what does supervision mean? And I tend to ask that question of considering the word vision on it. Does this mean that the anesthesiologist or the others is watching everything that nurse anesthetist does or is in that process, or is it they are merely responsible for cases?
Dr. Cronin.
That's a great question. In my practice, and I think the norm across the state for anesthesiologists, I will supervise between 2 and 4 rooms at a time. I'll always physically locate those rooms and assign those rooms based on 2 to 4 rooms that are all right next to each other. My time is spent in 3 main locations: in the preoperative area, in the operating room, and in the postoperative area. And it makes for a very busy day. We're constantly moving between those 3 channels, evaluating patients preoperatively, prescribing that individualized specific plan for their anesthetic. Then I'll travel to the operating room and check in on the case that's taking place at that time. Then I'll head 20 feet down the hallway to the recovery room and see how those postoperative patients are doing. And so it is direct, it is frequent. When I'm not doing any of those things, I might be looking at that chart from a geographic location of 10 to 20 feet, making sure that the vital signs are stable, those minor course corrections that we talked about with heart rate and blood pressure variability. And then immediately available for any emergencies means I'm seeing a preoperative patient in the holding room. I hear an anesthesia stat to room 9, and 15 seconds later, I'm in room 9 trying to diagnose what that medical problem is, and within seconds, prescribe a medical treatment for that problem. And that's what I mean when seconds count. You've got to accurately diagnose that medical problem, that emergency quickly, and you've got to prescribe a medical treatment that is accurate and correct quickly to maintain that safe, high-quality care.
Let me just follow up one
Follow
last
up.
one on that.
Last follow-up.
So in your practice model and in looking the efficiency of your practice, you need to be in an environment where multiple procedures are going on at the same time.
Well, some facilities that is true for. Some facilities that isn't true for. We take care of smaller ambulatory surgical centers where there's 1 or 2 operating rooms, and that second operating room might not be occupied that day. So it's not always multiple rooms. Sometimes it's only 1 room.
Representative Cunningham.
Thank you, Madam Chair. I have just 2 questions. He quoted that the old North State Medical Society had made a statement in support of the collaboration and supervision. Can you tell us who that is?
Dr. Cronin.
Well, I know that Dr. Charlene Green is the president of the Old North State Medical Society. And further membership of that society, I'm not aware of.
Follow up.
Thank you. Well, the reason I asked, because I want to know who prompted the support of what it is that you're bringing forth to us, and if you would provide that to us in writing, that statement, I'd like to see it. The Old North State Medical Society was established in 1887, and it is African Americans that established it. And the thing about it is, we're not in that era. We are in the 20th century, have dealt with COVID, and we're moving forward to try to expand health access. Lastly, you said that when you go into the operating room and you give the anesthesia, and then the person goes to the PACU. Well, when the person goes to the PACU or the recovery room, the anesthesiologist normally does not go with the patient, correct?
Dr. Cronin.
Not entirely correct. The PACU is definitely a part that we are frequently treating. If we check in on a patient and they're wide awake and their vital signs are very stable, then our contact with that patient will become increasingly less frequent. But emergencies happen in the PACU all the time as well. Things like re-intubations, respiratory distress, dangerously low blood pressure, those same cardiac arrhythmias, they can all happen in the recovery room too. And if they do, then our focus in a triage sort of sense becomes increasingly focused on that patient that's not doing well in the recovery room.
Follow up. I'm not gonna ask him any more questions, but I'm gonna make a comment. I've worked in the PACU, and I understand when the person comes out of the operating room and goes to the recovery room, it is staffed with specialized nursing, and the nurses are the ones that stay at the bedside, monitor all of the vital signs, and if an emergency arrives, she makes a call, usually to the leading surgeon or the leading physician that is handling that case, and then if it's a need to call anesthesia, they also call anesthesia. But the initial call is to the primary surgeon that led that procedure in the operating room. Thank you.
Any further questions from committee members? Representative White.
Thank you, Madam Chair. Dr. Cronin, thank you so much for being with us today, and thank you for your presentation. I do have just I want to follow up in kind of the line of questioning of Senator Hayes. Again, you continue to refer to the need for a doctor to be present in the surgical procedure room. Obviously, if it's a surgical procedure, the physician needs to be there. But over the last 2 years, because of COVID and because of some intermediary decisions that we made as a health committee to get us through the extreme COVID period. We did weaken some of, or temporarily do away with some of the rules and regulations for the nurse anesthetist and the APRNs. So right now, based on some of the stats that you've given us today, you've talked about 1,500 anesthesiologists in the state. We have 100 counties. We've heard from one senator today who has described that there are no anesthesiologists in either of his counties. So, and if you have a nursing background, which I do, and you have worked in hospitals and you've worked in the surgical areas, typically it is not uncommon for a nurse anesthetist to be in that room, and there's no anesthesiologist there. And that's across the state, and that's gone on for years and years and years. So I guess my question is, if nurse anesthetists can provide a safe environment, which they obviously do, unless you have some numbers to share with us to show that that is not correct. If they can provide an accessible environment for surgery, like in the counties that Senator Corbin referenced, why is the anesthesiologist so opposed when they know that they cannot be in every hospital, they cannot be in every clinic, they cannot be in every facility? Can you just give me a really simple answer about why the anesthesiologist, knowing that already today across North Carolina, nurse anesthetists are doing the job that you're saying to us can only be done safely by the anesthesiologist? Could you share with us exactly what it is that you do when you're not necessarily you, but your discipline does when there is not one of you there, never is one of you there in the facility, and yet the nurse anesthetist is doing their job every single day to keep patients safely through the surgery and alive after the surgery? It is just very difficult for me to understand when we know that there's 1,500 of you across the state. There is nurse anesthetists available across the state. For 2 years, we have not seen any, I'm not aware of any particular death or injury to anyone that's gone on. And yet, in my opinion, it comes down to a large amount of money that a nurse anesthetist has to pay the anesthesiologist to precept them, but it's not a clinical preception, it's a technical or administrative preception. So could you please help me understand how we are not safe with good licensed nurse practitioners who are anesthetists?
Dr. Cronin.
Yes, thank you for that question. I'll try and answer as much of that as I can. The SAVE Act definitely combines different advanced practice registered nurses. I'm not aware of any paid preceptorship between CRNAs and anesthesiologists. So I want to clarify that. There isn't any financial arrangement between an anesthesiologist and a CRNA. They work together as a team, and their pay comes from Medicare, Medicaid, and private insurers. There's nothing collaborative about that financial relationship. I do think that the anesthesia care team is the highest and safest quality of anesthesia care in this state. And I'm aware that that anesthesia care team does not deliver care in 100% of the state. But I think we should be working on ways to improve access, improve the anesthesia care team throughout the state, and continue to deliver to a broader and broader proportion of North Carolinians that highest quality of safe anesthesia care, given anesthesia's unique dangers within medicine. Our opposition is because I think anesthesiologists would oppose making those cases where there's not an anesthesia care team available the mainstream norm throughout the state, because of our belief that the anesthesia care team of anesthesiologists and CRNAs working together as a team provides the safest and highest quality care.
Thank you. Our time is up in this segment. Any further questions quickly from any other committee members? Seeing none, thank you, Dr. Cronin.
Thank you.
Dr. Cronin, I do want to add, the last time when you put me to sleep, obviously you woke me up, but my husband said, I'm not paying him to put you to sleep. I'm paying him to wake you up. If you don't wake up, he's not getting paid. And he meant it, so thank you for waking me up.
I think if you hadn't woken up, I'd have bigger problems than the payment.
Thank you, Dr. Cronin.
Thank you.
Next, we're going to hear about nurse practitioner full practice authority, healthcare access, and health outcomes from Vincent Guamo Ramos. I hope I'm close. And he is Dean and Vice Chancellor for Nursing Affairs at the Duke University School of Nursing. Thank you for being here.
Good morning, and thank you to the co-chairs, and thank you to the committee. I'm Vincent Guamo Ramos. I am the Dean of the Duke University School of Nursing and also the Vice Chancellor for Nursing Affairs. I'm a distinguished professor at Duke University, and I'm going to be talking about the role of nurse practitioners in transforming healthcare access and outcomes in North Carolina. As a way of I was struck by the previous speaker's comments in terms of real stories and making a personal connection. I just want to start by saying, for me, this is about health equity. And, I'm somebody who grew up in a community that was underserviced and that did not have healthcare access. And today, the primary reason why I'm here is because I care deeply about access for all. I care about improvement of outcomes, and I care about us collectively coming up with solutions to how we can advance and move forward. I'm going to start by sort of framing what I think has already been articulated. I think we've got an antiquated model in North Carolina. We've got ongoing restrictions to NP practice. I think really what represents the path forward is granting full practice authority to nurse practitioners in North Carolina. This would improve healthcare access and outcomes. Here's our current antiquated model. It's got sort of a snapshot of the United States and U.S. territories. A lot of this data Nicole already reviewed. But I think just to reinforce, we have 24 states, we have Washington, D.C., and we have 2 territories that have already passed full NP practice authority. And I think this is not a sort of an understatement. I don't think we're talking about innovation. We've got 3 decades of experience with the first states that authorized full practice authority in 1994. And once passed, this was a question that was asked, there's never been a state that has repealed this, and I think that's really important. This is not innovation. This is really about access and outcomes. So this is my vision of what I hope we will become. I envision a U.S. and territories where we will have full practice authority for nurse practitioners. As I've mentioned, as others have mentioned, I think this improves care access, it improves care outcomes, and also improves the workforce supply, which I think we all need. I'm going to present some data, and obviously data can be debated, but I tried to sort of pick the data that I felt was the strongest and that I felt was the most reputable. And so here is a report from the National Academies of Science, Engineering, and Medicine that is really a bipartisan body, highly respected scientific body that has put forward a clear statement. If full NP practice authority was adopted nationally, the number of Americans living in a county with primary care shortages would decrease by 70% overall, 65% in rural areas. Here's another study. This is a singular study, but I think an important one, so I've pulled it out. And so there are four sort of dimensions that I'd like to focus on. So here, what is being compared in the two columns are states with full practice authority as compared to states with reduced or restricted NP practice. And you can see the rate of avoidable hospitalizations is lower in states with full practice authority. You can see the percent of hospital discharges who are readmitted within 30 days is lower in states with full practice authority. You can see the percent of nursing home patients who are hospitalized per year is lower in states with full practice authority. And you can also see that state ranking for overall health outcomes is better in states with full practice authority. On each of my slides, I provide references and I provide the full citation. Here's the Cochrane meta-analysis that has been discussed previously. I think what's important here is that this is a systematic review, and in a meta-analysis, just for those that may not be as familiar, there is an attempt to try to take a broad range of studies and focus on those studies that can be compared, and then calculate what's called a pooled effect size, an overall effect. Is there an effect here? And what this particular Cochrane study and meta-analysis reveals is that nurse-delivered primary care as compared to physician-delivered care generates similar or better health outcomes. Another systematic review of 33 studies also showed no evidence for better NP care outcomes in states with more practice restrictions. Again, I really want to emphasize what's on the lower right-hand side of the slide. Greater restrictions did not equal better care outcomes. Here's something that recently was published in Health Affairs. And so the NP workforce is growing across the country. It's happening everywhere. But the NP workforce is growing much faster in states with full practice authority. And I think this is important. Today, a little bit of good news, and hopefully this will be well received. But today, the U.S. World News Report announced the rankings of the schools of nursing. And so Duke, the school where I happen to have the honor of being the dean, we're the #1 school in the state. We primarily train graduate nurses, nurse practitioners, and we're the second highest ranked school of nursing in the country. And there are probably just under 4,000 schools of nursing. This is a huge accomplishment. We are proud to train nurses. We are proud to provide care. And I think we should be concerned that nurses are making decisions. Our graduates are not staying in the state, and they're moving to states that have full practice authority because they see the possibility of addressing health as being more possible in terms of how we've been trained through our education, our license, and our competencies. Here's some data on this question of rural versus sort of other places where NPs practice. And the citation here is 2018, so I want to make sure the folks are clear because we had some discussion about the research. And so you can see here that full practice authority is associated with higher supply of nurse practitioners in rural and primary care health professional shortage counties. That's what that green line is. And you can see the yellow line is reduced practice authority, and the red is reduced practice authority. And so reduced being the worst in terms of having a primary care workforce in a rural county or in a health profession shortage area. So what would this look like if we were able to adopt this? And again, this is kind of my vision and my fantasy for the future. And, Nicole referenced this, but I think we have some observational evidence over the past 2 years. Over the past 2 years, we've had, a number, all those states that you see that are sort of colored in blue, not the green ones because those are full practice authority, but the ones that are blue, you can see that there were waivers, temporary waivers in response to the COVID pandemic. And what did that lead to? That led to increased capacity of a workforce to respond to a global pandemic. That led to a streamlined process for NPs to initiate care and place orders in the absence of any kind of physician signature requirements. That led to a more responsive healthcare workforce, a more responsive NP workforce. We were able to do our jobs because we didn't have the barriers. Here's some examples of us working. Two of those pictures are right here in North Carolina. That's at Wheels in Durham at a vaccine pop-up where we were very proud as a school that we were frontline in responding to ensuring that our community in Durham received the vaccine. You also have some examples of nurses, of nurse practitioners going into homes, into households, and directly trying to provide care to people in their homes to alleviate burden on healthcare systems and also to move the locus of care where it needs to be, which is communities. Another important fact, nurses are the largest segment of the healthcare workforce. We are 4 million strong. We provide the greatest amount of care across the globe. This is a fact that often goes unrecognized. For 20 years consecutively, we are the most trusted profession, the most ethical profession, and close to 90% of Americans report from this one study that they want the same access to care that they had during the pandemic, post the pandemic. This is about real people. It's about real communities. It's about improving health for everyone. Couple of final points that I'll make. NP practice restrictions, they contribute to inadequate care access, primary care workforce shortages. That's very clear from the NASEM report. They represent a barrier in terms of improving health outcomes. I would argue that they do represent a barrier to reducing costs. If people are not accessing primary care, that means that those conditions have greater acuity when they present themselves to our formal healthcare system. They cost us more. And we have tons of data from our country that shows that we spend a tremendous amount of money on caring for people that are very sick. We need to keep people healthy. We need nurse practitioners to do that. NP practice restrictions requirements represent an unsafe and fragile care model. And so what do I mean by that? Last week I was in Asheville spending time with nurse practitioners from across the state. And it was really striking, there was an opportunity in sort of a plenary session where folks were asked to come up and provide some of their perspectives on what's happening across the state. And I kept on hearing cases of two things that were quite troublesome. One, this idea of physician supervision agreements imposing unnecessary cost. Many of the nurse practitioners reported they were paying their physicians supervisors $60,000 a year, even greater, to actually do the job of caring for people in the communities where they work. And then also some reported concerns about the possibility of a disruption of that practice agreement. And imagine if something happened to that physician supervisor that was unexpected. They retire, they get sick, they move away. Then suddenly you have hundreds, if not thousands of people in an area who will lose their care. And that was really troublesome as I listened, and it was certainly something that gave me pause. And then the last point here is this idea of NP practice restrictions weakening our healthcare workforce. It is important that we be able to all respond, that all healthcare professionals are needed frontline, because in my view, there will be more times when our country will need all healthcare providers. And again, nurses being the largest, a very important segment of the population. My recommendation is that North Carolina grant full practice authority to the full extent of our education, our license, and our competency. I think that's true not only of nurses, not only of nurse practitioners, but of all healthcare professionals. And I would say, just as a final reminder, you can see here, again, data that Nicole presented, that 97% of North Carolina counties are classified as primary care health professional shortage areas. And you can see that we're ranked 31st among U.S. states in overall health outcomes. Those are things that we can do better and that we should do better. Thank you very much. I'm going to wrap up there and simply say there are lots of groups that are supporting the SAVE Act. It's not just nurses. And I thank you for your attention and welcome any questions. Thank you very much.
Thank you, sir. Representative Kidwell.
Thank you, Madam Chair. I'm sorry, I didn't expect to be first. Thank you for the presentation. A couple of questions, and I think it hinges to, oftentimes when I call the doctor's office, they'll ask me, are you okay with seeing the nurse practitioner? My response, typically being an accountant, is that cheaper? So, but also in my wife's care, she recently suffered a heart attack and sepsis, and has really spent a lot of time with a nurse practitioner that seems to do a fine job. So my question is, do we see a difference in outcome, the events of death and recoveries and things of that nature, when somebody's involved with strictly a nurse practitioner in other states versus the states that only allow for doctors to do the practice?
Thank you for that question. So based on my review of the data, what we see is comparable outcomes. So the places where healthcare providers, primary care providers are doing well, nurse practitioners are doing well. The places where we all can benefit and we all can grow, we're all struggling. So it's not that it's different. We have comparable outcomes. What I will say, and perhaps this will only matter to some, I think where there is a significant effect is that clinically comparable outcomes, but the patients actually enjoy the nurse practitioners more. They feel that there's more of a relationship, there's more time, it's a different kind of care. I should have mentioned that I am a nurse practitioner, a primary care nurse practitioner. I specialize in caring for people who are living with HIV, and I'm also a psychiatric mental health nurse practitioner, and I did that later, went back to school because I felt that I needed more education, and I saw that much of what I was seeing in primary care actually had a mental health component. So it speaks to the question of really broad training, specialization, and being able to kind of work within our competencies.
Follow-up?
Follow-up.
Thank you for that. Do we have any data on the cost savings for the medical industry as a whole, whether it be the patient, the insurance, when we have doctors versus using nurse practitioners in primary practice?
Dr. Ramos.
Thank you. Thank you for that question. So I would need to go back and look. To be honest, I don't have that top of head. What I will say is that I am certain the U.S. spends roughly $4 trillion a year in healthcare. We spend more than any other developed country. We spend about 50% of our overall expenses and about 5% of folks caring for people who are very sick. We need to rethink our models and focus on wellness and prevention. And I think that nursing and nurse practitioners in particular are sort of really trained to do that. And happy to follow up and would be more than and delighted to get you that information.
Final follow-up?
Follow-up.
So lastly, do we have any figures on, sorry, I'm a figures guy.
Sure.
Do we have any figures on the improved access to healthcare, being that this is the Health Access Committee? Do we have any figures in how we are doing in relieving the backlog, if you will, of access to health care when we allow nurse practitioners in primary practice?
Dr. Ramos.
Thank you. Thank you again for that question. So I guess what I would say, I think that in my presentation I presented some data on that. I think I showed that there was greater access and that better outcomes, and also I provided some information regarding medically underserved areas as well as rural areas, that having nurse practitioners increases the availability of the workforce. And so I'm not sure if I'm answering the question that you're posing, but in my estimation, I think that information was in the slide deck.
Representative Baker.
Thank you, Madam Chair, and thank you so much for the presentation. And I very much appreciate your concern for access. You know, I think we all agree on that, and that we want to get patients in rural areas, just like every area, covered. And I also appreciate Representative Kidwell's questions. And your slides do say, you know, if full practice authority was adopted, the number of Americans living in a county with primary care shortage would decrease. And I'm wondering, in follow-up to that and to Representative Kidwell's questions, if you could talk about the graduate nurse demonstration project that I know Duke was a key part of and had very clear outcomes about access.
Sure. So I think I want to answer that question a couple of ways. So first, you know, that finding is from the National Academies of Science, Engineering, and Medicine. And so again, just for the record, bipartisan group, focuses on science, focuses on evidence, no recommendation. I've served on those committees, and maybe many folks here may have as well. No recommendation comes from NASM if it has not been vetted, and it's not something that NASM can put forward. So that statistic is not so much my slide, it's really one of the findings from the report. And I think it speaks loud and clear that 70% of those shortages would be sort of relieved if we had full praxis authority across the country. So I guess that's the first part of the question. So could you say a little more about what you're asking about the demonstration project, the GNE project that was published in Health Affairs?
Right, so that project, for people who aren't familiar, was funded and required by the ACA when the Affordable Care Act came into place, and it was a demonstration project, and it had two goals. One was to increase the number of nurse practitioners, and one was to see if those increased nurse practitioners would go to rural counties. So that's the study I'm referencing, and wondered if you could speak to those outcomes.
Sure,
Dr. Raines.
cannot speak to those outcomes.
Okay. Well, thank you. And I do appreciate, I know Duke was part of that. And so what they did is they provided nearly $180 million to 5 different settings, and it was hospitals like Duke, community settings, and the point was to increase the number of nurse practitioners and increase those practitioners going to rural settings. So it was a great study that actually paired these nurse practitioners in these rural, clinical, underserved areas. And the outcome was that, in fact, the nurses went to urban areas post that major demonstration project that had a lot of money and was very well followed. They went to urban areas 91% of the time. And so their ability to serve rural areas was only 9%. In addition, the graduation rate was low, but they did turn out, more nurse practitioners, but those nurse practitioners did not go to rural areas, and the graduation rate of that project was only 37%. And again, I bring that up because, this was a very clear study that went to those exact points that you're talking about. We want more people in these areas, and that is a very rigorous study, very recent, and showed that that's not what happened. So I just wondered if you had some thoughts or insights on that.
Thank you, Representative Baker.
And then I have a follow-up.
Quickly.
Yeah, sure. Oh, sure. And then in terms of the Cochrane studies, I just think it's important, and obviously so much to discuss, so I don't want to overstep my bounds. So I appreciate your including that in the slide. I think it's important that in those studies, the diagnosis was not made by nurse practitioners. These patients were sent to these clinics after a diagnosis had been made by a physician. So I just want to be careful. It's very easy, these studies, it's hard to compare apples to apples, and I think it's important to know whether it was independent practice or not.
Thank you,
and
Representative
appreciate your
Baker.
time. Thank you.
Do you want to respond?
Thank you very much.
Thank you. Next, we have Senator Heiss.
Thank you, Madam Chairman. First, I want to say that, like most people, I'm not surprised we increased students in urban campuses and programs like Duke and got more people practicing in urban areas as a result of doing so. But I just wanted to get to this question, and I know he sat down, but one of his slides he really talks about, and I really want to get to the matter I think we're all really discussing, besides healthcare is moving all around. One of his talks about imposing unnecessary and excessive costs and passive income for physicians. Would you give us a little in-depth into what that passive income is? Because I suspect this entire argument of the day comes down to this quote thing called passive income.
So
Dr. Kwame Raines.
Thank you for the question. I was on my way back to my chair and realized that there was another question, so thank you. I guess what I will say is that the passive income really is synonymous with a practice that nurse practitioners in the state are reporting, that a physician will have a number of nurse practitioners who may or may not be geographically in the same place, oftentimes they are not, and they are paying for the piece of paper that gets signed that is the supervisory collaborative practice agreement. And in order to have that, you need to pay, and how they configure that, it can be a certain rate, it can be per patient. but it ultimately results in an unnecessary cost burden, and it winds up taking away from the nurse practitioner's earnings. Many of the nurse practitioners that I spoke with indicated that they knew of physicians that had multiple NPs, and this was another source of revenue for that physician.
Thank you. Representative Cunningham.
Thank you, Madam Chair.
We're not finished with you, Dr.
about that. I will stay here until I'm instructed to go back.
We are over time, so please make your questions quick.
Thank you. You were talking about the nurse practitioners and them exiting the state. Do we have any trajectory of percentages of those NPs that are exiting North Carolina? And if you can find some, will you provide them to us because we are still under restriction?
I will find them. I've got some homework to do with another question, and I will also find that out as well. I know that North Carolina is facing a shortage of nurses, about 13,000 by 2026, and so that's the base of our NP workforce, because those folks are typically the ones who come back and become APRNs. I will find that out.
Thank you. Last follow-up, Madam Chair. Can you give me a scenario, because in skilled nursing, usually they have a medical director on staff, they have the physician that is the lead, but he's not in the facility every day. He may have 3 to 5 nurse practitioners that are in the facility, and they're doing all of the ordering, they're doing all of the consultating, they're doing all of the assessing, and like you're saying is there's a physician actually sign off, but he may not be in that facility but once or twice a month. Am I correct?
Dr.
Absolutely.
Ramos. Thank you. Last question for Representative Farkas.
Great, and I'll be very brief. Thank you, Madam Chair, and thank you for your presentation today. I'm looking at this list here of all these groups that look like they're on board with the SAVE Act. It seems pretty diverse. To your knowledge, what groups oppose moving this APRN full practice authority like half the rest of the states in the country have?
Dr. Guamaremos.
So thank you for that question. I want to answer that by saying, my focus is really on health equity and education, licensing, and competencies, and NPs being able to practice at the highest level of those 3 things. I think you can look around the room and see who is in opposition, and I don't want to add to the tensions. What I want to say is that, to my knowledge, it's really specific physician groups. Thank you.
Thank you, sir. We appreciate your information. Next, we have Angela Mund. She is going to be talking about certified registered nurse anesthetist, full practice authority. And she is president-elect of the American Association of Nurse Anesthesiology. Thank you, Ms. Munn, for being here.
Good morning. Senator Kravick, Representative Lambeth, and members of the Joint Legislative Committee on Access to Healthcare and Medicare Expansion. That's a big sentence, and you're doing some really important work, so I applaud you for that in North Carolina. My name is Dr. Angela Mund, and I come before you today as the President-elect of the American Association of Nurse Anesthetists. I am a practicing certified registered nurse anesthetist for 24 years, as well as a U.S. Army veteran and a leader in nurse anesthesia education. Thank you for the opportunity to provide a national perspective on how full practice authority for CRNAs maintains quality and increases access to health care while reducing the cost of healthcare services. So a little background on CRNAs. CRNAs have been providing anesthesia care to patients for over 150 years. We practice anesthesia in collaborations with surgeons, anesthesiologists, dentists, podiatrists, and any other kind of qualified healthcare professional. CRNAs also practice in every single setting that you can think of, from the traditional operating room to ambulatory surgery centers, to the obstetric labor decks, to critical access hospitals, which I know you have a lot of rural facilities here in North Carolina, to the U.S. military. We are the #1 provider of anesthesia care to the U.S. military, the public health services, and in the Department of Healthcare facilities. In fact, CRNAs are the primary providers of anesthesia care in rural America. enabling healthcare facilities in these medically underserved areas to offer obstetrical, surgical, and trauma stabilization services. In some states, CRNAs are the sole provider in 100% of rural hospitals. In addition to providing the essential health care in thousands of medically underserved communities, I must again stress that CRNAs are the main providers of anesthesia care for women in labor, with 50% of rural hospitals using a CRNA-only model for obstetrical care. And importantly, CRNAs are the primary provider of anesthesia care for the men and women in our U.S. military. They serve on the front lines in every conflict around the globe. CRNAs serve as the backbone, again, in rural care and in medically underserved areas. In fact, Coomer et al. In 2019 indicated that CRNA delivery models in rural areas, they cover 61% in ambulatory surgery centers, 55% in small hospitals, and are present for 35% in large hospitals. To put a little personal perspective on it, I think you can clearly tell I am not originally from the South. Before moving to South Carolina, I grew up in a town of 1,000 in far northern Minnesota on the Canadian border. We had a small critical access hospital, and the only way that our hospital could stay open was the revenue that was provided from surgical services. We had a CRNA who lived in another small town, and he actually flew a plane so that he could get there to cover services in the critical access hospitals in our very, very rural county. As my parents got older, I have to tell you, having the knowledge that a CRNA was available and could be there. And the other thing I would say, and this goes to the congressmen who have no access in their counties, is it's very difficult for people, especially as my parents got older, to get in a car and have to get care 70 miles away, when what they really wanted to do was have their gallbladder taken out at home. So to think about that access, I think, is incredibly important. A study published in Nursing Economics found that CRNAs are providing the majority of anesthesia care in U.S. counties with lower income populations, and this is lower income across the board, not only rural, and in populations that are uninsured and unemployed. They also were more likely to be found in states with less restrictive practice regulations where more rural counties exist. And again, I will use myself as an example, is we had a very wide use of nurse anesthetists in Minnesota where we had full practice authority as compared to South Carolina where we have considerable restriction on our practice. This study also notes, and I will quote, anesthesia providers are not evenly distributed throughout the country, lending to the probability that different populations have disproportionate access to these providers. Compared to anesthesiologists, CRNAs are more likely to be found in counties where populations have lower median incomes, but also where unemployed, uninsured, and Medicaid are more densely populated. CRNAs provide anesthesia services to these vulnerable populations, and they help to deal with the disparities that we see in healthcare, and we see that more and more in light of the challenges that we had with those populations during COVID. Let's see. All right. So I want to speak a little bit to the military. So as a veteran, I can speak directly to CRNA care delivered to our active duty, reserve, and retired veterans. I received my education in nurse anesthesia at the Veterans Affairs Medical Center in Minneapolis, Minnesota. I delivered care to veterans every single day, and I went on to work as a CRNA in that same facility. CRNAs have been the main providers of anesthesia care to U.S. military personnel on the front lines since World War I, including recent conflicts in the Middle East. In fact, nurses first provided anesthesia care to wounded soldiers during the Civil War. So we have a long history in the South of being engaged, of having nurses provide pain management to patients as they were suffering traumatic injuries. Independent, and I will say that again, military CRNAs are independent. They provide care and trauma services in the most austere environments to both our military men and women, as well as, very importantly, the local civilian population. Our military CRNAs took care of patients in these environments, and I can talk about Afghanistan and Iraq, that they had never received surgical care. And what our independent CRNAs did there not only took care of patients, but really improved the reputation of the United States to these countries overseas. So if our military CRNA men and women are allowed to work independent of physician supervision, why are physician supervision requirements necessary when anesthesia is provided in large U.S. hospitals with incredible resources, including laboratory testing and radiology? In some VA facilities, CRNAs work independently and are recognized having full practice authority. Efforts are currently underway to provide for a national practice standard that ensures continuity across all facilities. For example, is you can have a CRNA with full practice authority in Idaho take care of veterans up there, and then when they go to Arizona during the winter, it's very different because it's much more restrictive. So a national practice standard is important for the VA. So the question becomes then, why do barriers to CRNA practice continue to exist? The data and evidence supporting the utilization of CRNAs to the full scope of their education and training is overwhelming and should be enacted in state law. Now I want to talk a little bit about North Carolina. So in North Carolina, there are 92 sites that are CRNA only. These include hospitals, surgery centers, endoscopy centers, and plastic surgery offices. So this is happening here in North Carolina already. In addition, there are 6 hospitals where CRNAs practice independent after hours and on the weekends. And you can see that these sites are distributed throughout North Carolina. And when we talk about access, I think it's also important to notice that there are over 3,500 CRNAs in North Carolina. Think about what we can do if we have a CRNA sitting in every single operating room and physician anesthesiologists also providing that care. As you pursue legislation supporting access to safe, high-quality health care for North Carolina patients, it is imperative that you eliminate barriers to CRNA practice. I want to mention briefly about the Institute of Medicine report that came out in 2010, and the title of it was The Future of Nursing, Leading Change in Advancing Health. And what the outcome of that was that their report was that barriers should be removed to increase access to care for all APRNs across all facilities. And it's important to note when you look at the IOM is it wasn't just nurses who developed it. Physicians were on this, and they all agreed removal of barriers is good for our country. In a survey of North Carolina statewide voters conducted by the Meeting Street Research in February 21, access to affordable health care remains an important issue for the voters in North Carolina. 2/3 of them noting that their elected officials need to focus on this area. And also as part of this survey, 74% of North Carolinian state voters support CRNA independent practice. I know that comes in conflict with what my physician colleague had to say, but it's important to know for anybody who does surveys is how the question is asked is incredibly important to the information in which is obtained. So now I want to talk about education. As an academic leader, I have expertise in nurse anesthesia education. I've been doing education for 20 years. I am now a department chair. I do not have, nor do I purport to have, expertise in physician anesthesiology education. I believe that it is important that each profession define itself, describe their education, describe their scope of practice, and describe their training. That is under the purview of the profession. And now I'd like to tell you a little bit about what nurse anesthetists do. Our students enter our programs with critical care experiences that are the foundation of safe anesthesia care. These baccalaureate-prepared registered nurses must have a minimum, that's a minimum, of 1 year of experience in an intensive care unit, with qualified applicants having closer to 3 years, which when we think about that, they have done 6,000 hours of intensive care experience to prepare them for the things that they will have to do as a CRNA. It's also important to note that in these ICUs, they are taking care of the sickest of the sick, they're managing crisis, they're diagnosing cardiac arrhythmias, they're diagnosing impending respiratory failure. Then they enter nurse anesthesia programs. The ICU is the easy part, folks. Then they enter our programs that are incredibly rigorous. Now they are a minimum of 36 months, and our students graduate with a doctoral degree which makes them eligible to take our certification exam. In their program, they not only learn anesthesia skills, but very importantly, they learn skills that are very necessary to be leaders in changing healthcare. How can we improve the care of our patients and the public? Our students are educated in all types of anesthesia delivery, from general anesthesia to nerve blocks and everything in between. They take care of every age group, from the very small to our geriatricians. We're experts in administering anesthesia and responding to emergency situations. A CRNA's anesthesia expertise complements a surgeon's surgical expertise. The surgeon should be able to fully focus on the procedure, while the anesthesia provider, whether it is a physician anesthesiologist or a nurse anesthesiologist, should focus on managing the anesthetic. When emergencies arise, standard operating procedures that both groups use respond, and it does not distinguish between type of anesthesia provider. They are identical for anesthesiologists and CRNAs. In fact, in an operating room, an observer might have difficulty determining whether an anesthesia provider is a physician or a nurse. So a little bit about cost effectiveness, because I know we have some of you deal in accounting and economics and are business people. So this was a study that was done originally in 2010 by Hogan of the Lewin Group, which is a very well-known independent group that takes a look at cost and cost analysis and ROI. So as you can see on this, a CRNA acting as a sole anesthesia provider is the most cost-effective model of anesthesia care. We actually had the study replicated in 2016, published in 2018, and the data is pretty similar. I just thought these tables were a little bit easier to evaluate. The important thing to notice with this is it was not published in an anesthesia journal. It was published in the Journal of Economics and Nursing Economics, very peer-reviewed. And as you can see, the only model that does that, that the revenue minus the total cost that is most cost-effective for the facility is CRNA only of what they're getting in revenue. What I would also point out with this is that this is taking a look at average demand. And as my physician colleague pointed out, is it's really difficult to say that we have 4 rooms open for everybody all the time. Surgical schedules change. Those things are really out of our control. So in reality, this is probably closer to what we are looking at in our facilities. And as you can see, the only one at this point that actually generates revenue minus cost in a positive way is the CRNA-only model. And you might ask then, well, how do facilities afford this if we are causing more cost without revenue? And you will see in many facilities what ends up happening is something called a gap contract, where the hospital pays the anesthesiology group to cover that difference in cost versus revenue. All right. Trying to make sure and not be redundant for y'all. But a couple things about during the pandemic at the federal level, CMS suspended the Medicare supervision requirement for CRNAs. It freed CRNAs to provide much needed patient care to the full extent allowed under state laws. And at the state level, governors in 12 states issued executive orders that waived supervision or other significant restrictions on CRNA practice. The removal of these barriers resulted in increased access to care without any evidence of reduction in safety or quality. In addition, 3 states took advantage of permanent removal of the CMS waiver: Oklahoma in 2020, Arkansas and Michigan in 2021. In addition, Arizona and Oklahoma permanently opted out of the federal CMS supervision requirement in 2020. And I'm going to speak briefly on that. The thing to keep in mind is the supervision requirement related to Medicare Part A under CMS is related to billing. It's not related to scope of practice. That is determined by state law. That's important to notice with that. The Federal Trade Commission has also weighed in numerous times in support of removing restrictions on APRNs, including CRNAs, and my colleague from the NCSBN addressed some of that. So hospital administrators, healthcare facilities of all types, policymakers, and healthcare providers must find ways to improve patient access to safe, quality care without burdening the healthcare system. The other thing to notice is the removal of supervision. It may not necessarily change what is occurring in our larger facilities. What it does is it allows each facility the option of determining the right anesthesia provider for the right patient at the right time, rather than one size fits all. And I think most of us can agree that putting that power in the hands of the healthcare facilities that know that and removing regulatory barriers is good for all of us. So the evidence is clear as to the cost effectiveness of CRNAs, but there are those that continue to question the quality and safety of the care we provide. The Institute of Medicine, the AANA, and the ASA concur that anesthesia is approximately 50 times safer today than it was in the 1980s. As the hands-on providers who are with a patient every second of every case. I'm going to say that again. The nurse anesthetist is in the room every second of every case. We are not anywhere but there, taking care of you, watching you, making sure that your heart is functioning well and your blood pressure is good. We're giving you anesthesia. And according to the results of a landmark study, I think I got ahead of myself, a landmark study conducted again by the Research Triangle Institute here and published in Health Affairs, there are no differences in patient outcomes when anesthesia is provided by a CRNA or a physician anesthesiologist or a team of a physician and a CRNA. They took a look at nearly 500,000 individual cases and confirmed what previous studies have shown. CRNAs provide safe, high-quality care. I would also note that we also had a Cochrane collaboration study, and the value of that, and I appreciate my colleagues addressing that also, is the Cochrane collaboration has a very high threshold of what they consider is publishable in their library. And what the Cochrane collaboration study found was that there was no difference that they could find between CRNAs, physician anesthesiologists, and teams. So removal of barriers to practice, and I know you've seen some of this already. So over the last 20 years, states have continued to recognize that removing barriers to practice for APRNs is good for their communities. If they didn't, we would not continue to make progress in this area. There is clearly still work to do, but removing barriers has not been detrimental, or again, states would not continue to move in this direction. Further, on a nationwide basis, the average 2021 malpractice liability insurance premium for self-employed CRNAs, and I will note what we saw during the pandemic is self-employed CRNAs practicing independently using a QZ billing modifier has skyrocketed during this time as CRNAs have continued to work independently and to move into areas and provide anesthesia in ICUs and in a variety of other areas. So 36% reduction in premiums since 1998, and even when trended for inflation, the reduction in premium is 73% less. If we were unsafe and there were large malpractice claims, one would think that insurance premiums would rise rather than fall. Also, working with the CRNA does not increase the liability of other healthcare providers, because it is important to note when we talk about supervision related to surgeons is the only time they have ever been held liable for the actions of a CRNA is when they have directly directed the CRNA in what they shall do as far as the anesthetic. And again, we have some work to do down in the South, and even though North Carolina is better than my home state now of South Carolina, I would still like to see all of us in the green. So in conclusion, I'd like you all to keep in mind that regardless of any legislation that's passed, CRNAs will still adhere to national certification and accreditation standards, as well as hospital and facility bylaws. CRNAs never have and never will function in a vacuum. We truly believe we are ICU nurses, and we are the master collaborators in that role. We work with everybody. And as a CRNA, we will do the same, despite whether supervision is removed. So I want everyone to be mindful that it is incredibly important that we don't talk about patient safety in ways that is alarming to patients and has them believe that they are not safe in our operating rooms. I would also have you take a look at any studies that may arise, that are presented to you both by the AANA and by the ASA. Take a look not only at the merits of the data themselves, but where they are published. And you will see that the majority of the publications that the AANA has supported has been independent researchers and are not published in anesthesia journals. They are published in health affairs, nursing research, and healthcare economics. And I would like to address the one study related to safety, because I have to admit that as someone who takes care of patients every day, I'm always concerned when we come out with language that leads patients to believe that they're unsafe. Is the study that my physician anesthesiologist colleague quoted was one that was done in, I think, 2000. And the thing to notice with it, and I'm going to quote this because it came out of HCFA, which is now CMS, and what they said about that study was this: one cannot use this analysis, the Silber study, to make conclusions about CRNA performance with or without physician supervision. So when we were removing supervision, working on that at the federal level, CMS acknowledged that that study was not valid. And I would caution you to use that. The healthcare landscape in the United States is changing rapidly, and professionals whose services result in cost-effective, high-quality, safe outcomes are really needed now more than ever, and we saw that during COVID. CRNAs play a critical role in meeting this challenge by providing safe, quality anesthesia care at a cost that ensures access to anesthesia for millions of Americans. I urge you to support the SAVE Act. Thank you for your attention, and I look forward to taking any questions.
Thank you. And members, we are over time, so please make your questions brief if you can so we can get back on schedule. Representative Potts.
Thank you. I'll be brief with the two-part question. Thank you for your presentation. First part, what is the minimum years of education or time spent to become a CNRA? And secondly, if given the full scope of practice, I'm having trouble finding the need for an anesthesiologist. If you can do this, why go to medical school and residency and internship and have an enormous amount of debt when you can do the same thing with a lower degree? So I see the anesthesiologist as becoming a dinosaur unless they can find a niche for practice. Thank you.
Ms. Munn.
So I'm going to address the second part first, because in no way am I advocating for removing the anesthesiologist from the healthcare environment. In absolutely no way. There is enough work for all of us to go around. All I'm saying is that facilities should decide how that access is used. Academic health centers that educate residents, very clearly we need anesthesiologists there, because anesthesiologists should be educating other anesthesiologists. So again, in absolutely no way am I advocating, or my national organization advocating, for anesthesiology to end as a profession. I do want to make that very clear. I have worked in anesthesia care teams and have collaborative relationships with some of my anesthesia colleagues. So I do really want to make that clear. As far as education, we really have changed over time. Right now, so anybody entering my program at this point, they have at least a 4-year baccalaureate in nursing. Probably a third of my students also have degrees in other things, including business, psychology, exercise science. We often have dual degreed ones coming in. So minimum of 4 degrees, fast as you can do it. The other part with that is now it's a minimum of 3 years in a nurse anesthesia academic program. Nurse anesthesia started requiring the master's graduate degree in 1998 for anybody entering programs. The majority of the length of those programs was 27 to 28 months. So if you take 4 years plus 2.5, 6.5 would be the absolute minimum. And the other thing to keep in mind is that our education also includes that ICU time. That's when we are learning to be ICU nurses. They take continuing education, continue to learn during that time. So I think it's difficult to put a number on it because there's so many different ways and avenues. And we all do come out with a clinical doctorate. Our education is different. And also, the other thing, Representative Potts, is that I really would like to add also is it's important to notice the difference in clinical hours is how we count them is different. It's apples and oranges. Our nurse anesthesia students can only count the time they are in the operating room delivering an anesthetic. It's not the time they're waiting in the hospital for patients to come down or delays or preparing. So I would caution you in comparing those two really as the same thing. They truly are not. We count them different according to the requirements of our accrediting agency. Did I answer your question okay?
Thank you. Representative Cunningham.
Thank you, Madam Chair. My interest is in during the COVID pandemic, respiratory therapists intubate. And I was wondering what the demand was to pull more advanced nurse anesthetists in to help intubate, because usually specialist doctors that are in respiratory or lung disease, they have that expertise to do that, but they're not always available. So during the COVID, what did we see the kick in for the CRNA inside of our facilities?
Ms. Munn.
Thank you. Is what we really did see is, as I said before, CRNAs want to be partners in improving healthcare. We really do. And I have a colleague in New York. I have a lot of good friends up there that really did see the brunt of it at the beginning. And CRNAs, because elective cases were canceled, they moved into the ICU. A colleague of mine served as the intensive care CRNA in a community hospital for several months, and she was responsible for all of the ICU management, all of the airway management, all of the central line management, as well as talking to families and comforting scared patients. So we really did move into those areas. We saw it a lot, again, in the Northeast, probably more than what I've seen in the South. We also saw it in our VA facilities, is our CRNAs, due to the canceling of elective cases and overwhelming the system in the ICU, CRNAs moved into those roles also. Thank you for that question.
Representative Baker, quickly.
Thank you, Madam Chair. I promise I'll be brief, and thank you so much for your presentation and your dedication to patients. I feel incumbent upon me to reiterate when you said, the outcomes are not different. Independent studies have shown there's an 80% greater chance of a nurse anesthetist, a patient in that care, and that's an independent study, having basically a bad outcome, either hospital or death. But then you mentioned, the patient may not know whether, it looks the same, the practice looks the same. They may not know if it's a nurse anesthetist or an anesthesiologist. And then you mentioned malpractice claims. And so to my knowledge, we are still in North Carolina under malpractice laws that do not allow a patient who might not know the difference and who's taking care of them the ability to hold the nurse entirely accountable for that outcome. And if I'm not right, I'd appreciate it.
Ms. Munn.
Thank you. So I can speak to that in two ways. Number one, I'm not familiar with North Carolina state law, so I am not going to take a guess at that for you. But case law across the country really has said the captain of the ship doctrine, that I think is a lot of what we talk about, does not apply anymore unless the surgeon specifically directs the CRNA to do something. Then they become liable for that responsibility. And the first one, are you quoting the Memsauda study? Is that the one you're looking at? Okay. So there are some challenges with that one too, is they only looked at two types of surgical cases. They took a look at data over from 1996 to 2006, and what we do know is that anesthesia became safer over that time. So making comparisons probably it might be a little bit of a stretch to take a look at that. The outcome was not anesthesia specific, and what we saw in the Silber study and in the Memsauda study is they took a look at data over bigger time when we know that the anesthesia impact, when we're going to see true morbidity and mortality and how we report to Joint Commission is like 48 hours worth of time. So to try to say that a 30-day mortality is really under the purview of myself as a CRNA or a physician anesthesiologist is not entirely correct, because we know that postoperative care is often provided by a physician who's may not be anesthesia related. So I can provide you with some information related to those studies if that would be helpful, as when we've had people look at it. And I would also say it may have been conducted by independent researchers. However, it was published in an anesthesiology journal.
Right. And
Follow up quickly.
I'm sorry.
Very quickly.
Okay. Yes, we can discuss that further. Yeah, I think that it was a mirrored study, so that enhances the accuracy. But thank you.
Yep. Thank you very much, Ms. Munn. We appreciate the information. Next, we are going to hear from Amy Cole, the Director of Advocacy and Government Affairs at the American College of Nurse Midwives. And she's going to talk about, excuse me, nurse midwives' full practice authority and the benefits for North Carolina.
Thank you.
Oh.
Can you all hear me?
We can.
Okay, perfect. And I'm going to share my screen. All right, can everyone see that okay?
We can. Thank you.
Fantastic. Thank you so much. All right. Well, good morning. My name is Amy Cole, and I'm the Director of Advocacy and Government Affairs for the American College of Nurse Midwives. On behalf of North Carolina's 497 certified nurse midwives, I appreciate the opportunity to provide testimony in support of the SAVE Act. I would also like to thank the committee for conducting this hearing and for accommodating my inability to join you all in person for this important discussion. So thank you very much for allowing me to zoom in. So to bolster my prepared comments, I am going to just start off with this quick point slide you see in front of you. And I'll just go over these real quick. So I'm sure it's not any news to anyone on the committee or anyone there in the audience that the United States continues to face a maternity care provider shortage that is disproportionately impacting people in rural and underserved areas. The shortage of OB-GYNs, coupled with a steady decline in primary care physicians, emphasizes the need to increase the number of full-scope maternity care providers. Access to care provided by certified nurse midwives has been shown to produce high-quality outcomes at lower cost. North Carolina is one of 3 states with the most restrictive requirements for nurse midwifery practice in the United States. And recently, March of Dimes has updated their annual report card. North Carolina has received a D rating in 2021 in the March of Dimes report card assessing infant and maternal health. So given all of that, I'm going to move to my prepared comments, and I'd like to preface my prepared comments by saying that in addition to being a government affairs professional for over 20 years, I'm also a proud consumer of midwifery care. As certified nurse midwives at George Washington University Hospital in Washington, D.C., attended the births of both my children in 2013 and 2014. That said, I was born, raised, and still reside in the great Commonwealth of Virginia, but when I started to inquire about access to midwifery care in Virginia at the time, I quickly learned that I would have to cross state lines to Washington, D.C. to have access to a hospital-based midwifery practice able to provide full-scope midwifery care. Thankfully, the Virginia General Assembly decided to follow the path of other states, and during last year's legislative session, the remaining barrier to midwifery care was removed and full practice authority was granted to nurse midwives so that future maternal health consumers will have choices and access to a wide range of maternal health providers. I certainly hope that North Carolina will follow suit. So, improving access to midwifery care helps ensure that all people are served by a maternal health system that delivers safe, effective, timely, efficient, race-concordant, and patient-centered care. Midwifery is part of the solution to addressing our nation's abysmal maternal health crisis. And I'm going to go to the next slide. Sorry, bear with me as okay. To increase access to board-certified nurse midwives and midwifery-led care, we must address barriers that prevent midwives from serving their communities. This includes amending regulatory structures that require supervision or collaborative agreements as a condition of practice for certified nurse midwives and other advanced practice registered nurses, and by establishing a robust and diverse APRN workforce. This brightly colored infographic, I use this often on Capitol Hill, and people love it because it really, we can drone on and on and on about regulatory structures, but what people really like to know is, okay, when we talk about where in the United States are certified nurse midwives able to provide full scope care as part of a team-based practice, green is good, yellow, not so good, red, terrible. So we use this often, and this showcases the regulatory environment for certified nurse midwives nationwide. And as you all can see from the map, which I'm sure you've seen before, North Carolina joins Georgia and Nebraska as the most restrictive states for nurse midwifery practice in the U.S. We can and must do better. By way of background, the American College of Nurse Midwives is a professional association that represents certified nurse midwives and certified midwives in the United States. Our members are primary health clinicians who provide evidence-based midwifery care for women throughout the lifespan, with an emphasis on pregnancy, childbirth, gynecologic, and reproductive health care. ACNM works to promote equity, diversity, and inclusion throughout the midwifery profession and across the care continuum to ensure better healthcare outcomes for the people midwives serve. All midwifery education programs associated with the certification of the certified nurse midwife are located in or affiliated with institutions of higher learning that are accredited by an agency recognized by the United States Department of Education. Midwifery graduate programs accredited by the Accreditation Commission for Midwifery Education, or ACME, grant master's degrees or higher. CNMs are certified by the American Midwifery Certification Board, an autonomous certifying organization accredited by the National Commission for Certifying Agencies. The functions of the AMCB include initial certification of CNMs for entry to clinical practice, recertification, and discipline. Candidates must graduate from an ACME-accredited program to be eligible to sit for the national certification examination administered by the AMCB. Certified nurse midwives provide a full range of primary health care services to women at all stages of life, from the teenage years through menopause, including general health checkups, screenings, and vaccinations, pregnancy, birth, and postpartum care, well woman gynecologic care, treatment of sexually transmitted infections, and prescribing medications, including all forms of pain control medication and birth control. CNMs work in a variety of settings, including hospitals, university medical centers, private practices, birth centers, military hospitals, family planning clinics, health departments, and home birth practices. The ACNM sets the national educational and practice standards for certified nurse midwives. Entry-level competencies that must be mastered in all education programs are based on ACNM's core competencies for basic midwifery practice, the standards for practice of midwifery, the philosophy of the ACNM, and the code of ethics. This framework is the foundation for clinical competency and patient safety. These standards and competencies adhere to international standards and guidelines for safe and competent entry-level nurse midwives. The American College of Obstetricians and Gynecologists recommends in their National Guide on Team-Based Care that states rely on these uniform clinical guidelines and the standards set by professional associations when licensing and regulating professionals. Nurse midwives meet these standards of competence prior to graduating and being granted admission to to take their board certifying examination. Excuse me. The ACNM position statement on independent midwifery practice is explicit that independent does not mean alone and that any prudent clinician will seek advice of other qualified clinicians. Collaboration can only occur where there is mutual respect and communication and where each professional provides care within their respective scope of practice. CNM care incorporates appropriate consultation, collaboration, and referral as indicated by the health status of the individual receiving midwifery care. Midwives build relationships in their communities and regions with other clinicians. It is these relationships and our standards that lead to safe outcomes for people receiving care by CNM. So now that we've had a crash course on what it takes to obtain the CNM certification, I'm going to share a little bit about why passage of the SAVE Act is critical to improving the culture of maternal health in North Carolina. The United States is in the middle of a growing maternal health crisis that was exacerbated by COVID-19, especially in rural and underserved areas. Current trends and inequities in maternal health show that we're not doing a good job of financing a system that supports high quality, equitable care during pregnancy, childbirth, and postpartum. The United States has the worst maternal death rate in the developed world. Maternal morbidity and mortality are on the rise in the United States while decreasing elsewhere, and the U.S. continues to face appalling racial and ethnic disparities in the delivery of and access to maternal health care. Recent CDC data from 2020 indicates that North Carolina ranks 44th in the United States for infant mortality, 43rd for low birth weight, and 39th in the U.S. for preterm birth. You can probably guess where I'm going with this. What do all of the states that rank worse than North Carolina have in common? Some level of regulatory restriction in place for nurse midwives. On the contrary, many states that have passed legislation similar to the SAVE Act during the past decade have seen a decrease in cesarean birth, preterm births, stillbirths, birth trauma, severe blood loss, low birth rates, and NICU admissions. Coincidence? Perhaps. But if I were a betting woman, I wouldn't chance those odds. And I know the causes for escalating rates of maternal mortality and morbidity are complex, but we do know that it does include a shortage of qualified maternal health clinicians. And there is a correlation between how well midwives and midwifery-led care models are integrated into the care continuum and maternal newborn outcome. Poor coordination of care across providers and birth settings has been associated with adverse maternal newborn outcome. A 2018 PLOS midwifery integration mapping study suggests that integration of midwives into regional health systems is a key determinant of optimal maternal newborn outcomes. Evidence supporting midwives and midwifery-led care for low-risk women is vast. When women are placed in an appropriate level of care with the appropriate provider, maternal mortality and morbidity rates decrease. Midwifery care provided by CNMs can reduce maternal and neonatal mortality, rates of stillbirth, perineal trauma, instrumental births, rates of severe blood loss, preterm birth, and low birth weight, and neonatal hypothermia. Midwifery is associated with more efficient use of resources, shorter hospital stays, and improved outcomes, including increased rates of spontaneous birth, spontaneous labor, vaginal birth, and breastfeeding. Women who receive midwifery care have reported higher rates of satisfaction with care, pain relief in labor, and maternal newborn interaction. To date, the characteristics of an integrated system have not yet been linked to health disparities, but this is likely to be changing soon, courtesy of the Centers for Medicare and Medicaid Services recently announced birthing-friendly hospital designation proposal, which, much like Medicare's existing hospital and nursing home compare site, will seek to identify hospitals that provide high-quality perinatal care, are participating in a maternity care quality improvement collaborative, and have implemented recommended patient safety practices. How a hospital rates will be determined on a series of factors likely to include access to nurse midwives able to provide full-scope midwifery care to low-risk women. And I say likely because this is just a proposal, and we've had many conversations with CMS. Nothing has been released right now on how this will unfold, but they know that there is a synergy between better integration of midwifery-led care and midwives into health systems and improved outcome. States where statute and regulations support a CNM's ability to practice midwifery and provide patient-centered care in the way they were educated, trained, and certified to do, unencumbered, have more midwives on care teams and have better outcomes than states where a nurse midwife must obtain a physician's permission in order to work. Midwifery and medicine have overlapping but distinct education and training that reflects the different scopes of practice of each respective profession. The recognition of doctors and midwives as equal and complementary partners in the reproductive health care requires respect for a nurse midwife's field of expertise. The ability of a nurse midwife to function within North Carolina's health system should not be tied to the inclination or availability of any one physician. A CNM's education and competency standards follow rigorous national accreditation and validation, and CNMs must prove themselves able to diagnose, manage, treat, consult, and refer independently prior to graduation and sitting for their board. The ability of midwives to function to their full scope of practice in community settings in collaboration with other members of the health system can enhance cost effectiveness of maternity care. Current evidence suggests that scope of practice laws, as well as other aspects of state policy and regulation, may be reducing the maternity care workforce and access to services. Furthermore, access to healthcare in the United States is shrinking. According to recent data published by the Association of American Medical Colleges, the United States could see an estimated shortage of between 37,800 and 124,000 physicians by 2034. Including shortfalls in both primary and specialty care, including obstetrics and gynecology. Yet, midwifery is underutilized by most patients. Midwifery as practiced by nurse midwives has the potential to expand access to culturally congruent, high-quality care, with nurse midwives already attending roughly 10% of the births annually and providing primary and maternal health care in all settings. About 97% of all midwifery-attended births take place within a hospital setting. The need to effectively utilize CNMs has never been greater. Yet there are significant barriers at the state level that reduce access to CNMs and midwifery-led care that must be removed to ensure the provision of high-quality care continues. Supervision requirements in particular act as a barrier to entry in underserved communities already facing provider shortages, as finding a supervising provider to serve in this capacity may prove especially difficult in these areas. Evidence has shown that states with restrictive regulatory requirements, such as strict quotas on the number of CNMs a physician is permitted to supervise, typically report a smaller supply of midwives per capita and lower rate of CNM-attended births. The body of evidence on this topic has consistently shown that although these barriers do not improve patient safety, they do negatively impact cost, access, and quality. Required supervision regulations introduce a level of rigidity into the healthcare delivery system that often bears significant economic costs without demonstrated patient safety benefit. Midwives and other APRNs have spent decades defending their ability to do the jobs they were educated, trained, and board certified to do. It's time to follow the evidence and economics and remove supervision as a condition for practice. Removing the supervision requirement as a condition of practice for nurse midwives in North Carolina would allow a significant scale-up of midwifery across the state over the coming years and could help improve upon the aforementioned vital statistics data. Scope of practice restriction requirements are anti-competitive as they give one group of healthcare professionals the ability to restrict access to the market by a competing group of healthcare professionals, thereby denying consumers the benefit of greater competition. Statute and language that restricts scope of practice tethers midwives geographically and economically to where physicians already practice without providing any actual oversight. This worsens the maldistribution of maternal health care providers in the areas where the most vulnerable populations already lack access to care, and during a time when the United States is facing a dangerous physician shortage. Integrated team-based care, which includes certified nurse midwives and other APRNs, is the future of healthcare in the United States. The restrictions to CNMs and other advanced practice registered nurses puts people at risk and places additional stress on the nation's already challenged healthcare system. ACNM urges lawmakers to lift restrictive licensure requirements that limit access to the midwifery workforce to ensure that CNMs and all APRNs are able to practice to the full scope of their education to certification. Increasing the number of certified nurse midwives is part of the solution to the primary and maternity care provider shortage plaguing many of the rural and underserved areas in North Carolina. Decades of research and hundreds of studies have documented that care by CNMs is safe and the most prudent use of increasingly scarce resources. There is wide support for reducing unnecessary state and federal practice restrictions and barriers to accessing care by care provided by certified nurse midwives and other APRNs. The Department of Health and Human Services, the National Governors Association, the National Academy of Science and Medicine, the Federal Trade Commission, the Medicaid and Ship Payment Advisory Commission, the American Nurses Association, and I could go on and on and on, are all part of consumer groups, provider groups, and think tanks that have supported or recommended increased access to midwives and midwifery care models, and that CNMs be able to practice to the top of their scope. And I understand change can be scary, but maintaining the status quo is arguably much scarier, especially within maternal health. I implore you to follow the evidence and economics and the lead of 28 states and Washington, D.C., and let board-certified nurse midwives, nurse practitioners, nurse anesthetists, and clinical nurse specialists care for the people of North Carolina the way they were educated and trained to do. Thank you so much for allowing me to join you virtually. And I appreciate your time, and I will take your questions. I think maybe I'm giving you a little bit of time back here.
Thank you, Ms. Cole. Members, questions? Senator Heiss.
Thank you again, Madam Chairman. One of the things I just wanted to emphasize kind of on this and dealing with nurse midwives, as Senator Corbett can attest, we in Western North Carolina are still dealing with the concept of Mission Health before it was HCA, closing 2 of our birth centers in Western North Carolina and not having any ability to really losing the entire concept of OBGYN care in a lot of our communities and others. But the challenge we face without being able to expand nurse midwives is the rise of professional midwives. And I use that kind of with a quotation on it. I think last I heard there are requirements where you have to watch 20 births and you take a 20-hour course and you were quote-unquote a professional midwife, and probably about 8 years ago, we had a very tragic event happen in Buncombe County where a professional midwife was stepping into this role and providing services. And as there is a growing request for at-home services, while that may not be a ideal environment for delivering a child under any circumstances, it's continuing to grow as access has really been taken away by the healthcare system and the others. If we don't have an opportunity in those rural communities to fill that with a viable option that the nurse midwives could portray, we're going to have the non-market fill that service in either way. And so I didn't know if the presenter or others would like to speak on that different concept, and they get confused because they use the same names of professional midwife and the risk that that truly does propose in healthcare.
Ms. Cole.
Yes, thank you for that question. And that is something that we grapple with, as you can imagine, at the federal and state level, because no one in the United States really understands what a midwife is, because there's a lot of conflation, because no one really owns the term. There are certified professional midwives, which you are talking about. That is not who we are, who we represent. And I would say, as far as workforce, I mean, I hear what you're saying. One of the things that we are working on at the federal level is targeting federal funding through Title VIII Nursing Workforce Development Program, specifically for accredited midwifery education programs. So our program at East Carolina University in North Carolina, for example, should this legislation come to pass, would receive federal grant funding to help increase the number of students, so people wanting to go into the profession of nurse midwifery. We do recognize that we, as I demonstrate or said in my comment, that there is a workforce shortage in maternal health space. And so we are very cognizant of that. At ACNM, that actually is our #1 policy priority outside of full practice authority for the people we represent, certified nurse midwives. So that would be helpful. I mean, that will be helpful to the state of North Carolina, because the way that the language is structured is that if a program like ECU were to receive a federal grant, they would have, part of, the student receiving that money would be having to go out and be deployed through the National Health Service Corps to provide, 3-5 years of work in a health professional shortage area. Which it sounds like, there are many of in Western North Carolina. So that's one of the things that we are focused on, recognizing what you said about lack of access to any type of obstetrical care in many states around the country.
Thank you, Ms. Cole.
Yes.
Thank you for the presentation. We appreciate your joining us. Thank you so much.
Thank you.
Next, we have Jordan Roberts, Director of Government Affairs at the John Locke Foundation, and he is going to discuss granting nurses full practice authority benefits for North Carolina. Welcome.
Thank you. Madam Chair, co-chairs, members of the committee, thank you all so much for the opportunity to come here and present to you all this morning. My name is Jordan Roberts. I'm the Director of Government Affairs for the John Locke Foundation, and prior to this role, I spent 2.5 years as a healthcare policy analyst at the John Locke Foundation, writing, researching about all things North Carolina healthcare policy related. And yes, I'm here today to present on what we see as the benefits for North Carolina of granting nurses full practice authority. So first, I wanted to start and sort of just frame my presentation in terms of some of the problems that I see with healthcare, healthcare access. And something that I often find is that I think when we talk about healthcare access, there's two different ways we can talk about that. We can either talk about raw numbers of people who are covered by health insurance, or we can talk about actually having readily available access and ability to receive medical care. Like Senator Corbin said, if you are in his district and you have an insurance card, you're covered, but you can't actually access any readily needed medical care. So I think that we need to be specific, and I would argue that we should focus on the latter instead of the former. Two, I think we need to re-examine the delivery of healthcare. I think we have a system full of really good providers, but it's a system that has really bad incentives, including the payment incentives, and oftentimes that stacks the deck against the patient and pits industry players against each other, sort of all, again, working against what should be the goal of this, which is good health outcomes at the most affordable cost. Next, the Affordable Care Act and the growth of North Carolina's Medicaid program. This increases the demand for healthcare services, and it's my opinion that we really haven't done anything to increase the supply. And just on a basic economic level, we know that when demand for services increase and supply doesn't meet that, prices go up and there's problems with access. Next, as we've heard a lot throughout these different presentations, we know the problems with shortages, but especially with North Carolina's geography, we suffer from a maldistribution of providers too, so just something to keep in mind. And then lastly, which I'll talk about a little bit more in my presentation, but there are declining numbers of primary care physicians entering the workforce. And when we talk about healthcare access in the state, you'll notice I'll focus a lot on primary care. So this is something just to keep in mind as we look towards healthcare reform in the future. So what I believe we need to do is fully deploy our healthcare infrastructure and our healthcare resources that we have in this state. And current laws, we've heard, limits APRNs from practicing at the top of their license at the fullest extent of their training. And like we've also been talking about, these reforms in the SAVE Act, these will allow nurses to practice freely and at the top of their license. And I want to draw, this chart is from an article that was published in 2018 in the New England Journal of Medicine, and I want to draw your attention to the column on the far right. This is the projected average annual growth rate of 3 different professions: physicians, nurse practitioners, and physician's assistants. And as you can see, nurse practitioners and physician's assistants are projected to grow much, much faster in the coming years. And so if we think about how to reform our healthcare system and how our state can adapt to meet the needs of what our citizens need, we see that the projections show that nurse practitioners and other advanced practice registered nurses have similar projected growth rates. And so we know what the problems are. We know how the market or the workforce is going to adapt. So again, something to keep in mind as we're talking about the reforms in this proposed legislation. And what I would like you all to think about this bill in terms of a regulatory reform issue. Oftentimes, members of this body, members of the public will come before you and say, we have a problem with the regulation, it's raising costs, it's limiting my ability to practice, and that's a lot of time what this body looks at, and that's what we have here. We have a regulatory reform issue that limits access to critical services, it raises costs, like we'll talk about in a minute here, and it limits the ability of highly trained professionals to practice at the top of their license. So this checks all the boxes of a regulatory reform issue, and I think it gets bogged down with a lot of the passion around this issue, but at its core, that's what it is. And I won't go, we've touched on these 2 charts here, but I think the main thing I want to make a point of here is that legislators often like to see how we compare to other states, and it's my opinion that with all of the APRNs, we're falling behind other states that have realized this need and accepted that they need to make changes to adapt to their coming workforce challenges. So these are not new or novel ideas. States have made it work, and like we've seen, there's no significant stories of any bad health outcomes or anything like that. So I really wanted to focus part of my presentation on the cost and tax benefits associated with full practice authority. And I wanted to highlight, which I'm sure a lot of you are familiar with, but a study done by Dr. Chris Conover in 2015. And the bottom line finding of this was that granting full practice authority will lower healthcare expenditures and create higher tax revenues for North Carolina. And the way that he does this, and which I think is a very robust model, he builds an economic model that builds in all these variables about projected consumption of healthcare, the costs associated with where we get that healthcare, and I have no reason to doubt anything in that model. And so remember, this study's a little bit, a few years old, so these findings are in 2014 dollars, but what Dr. Conover finds is a annual health cost savings, so this is a reduction in health expenditures associated with full practice authority, a lower end estimate of $433 million to an upper end estimate of $4.3 billion. And again, these are raw reductions in health expenditures in our economy. And then two, the other part of this is that with more with APRN's ability to participate more in the economy and in their own businesses, we have an increase of tax revenue too. So just an added bonus onto this reform is that we can actually increase economic activity and collect more taxes in the state, and that's on personal taxes and taxes on production and imports of their practices. So where do these cost reductions come from? Training costs are lower. So from an economic standpoint, we have scarce resources to get professionals in the field, namely time and money. And what we know from the research is that these professionals cost less to train, to get out in the field, to deploy, like we've heard, a lot of the same services. Next, compensation and reimbursement levels are lower. In a lot of cases, physicians and APRNs are providing the same services, but physicians are paid at a higher rate. As we talked about, this supervision adds a layer of administrative costs and administrative bloat onto the practice. And with this idea of supervision, a lot of times there can be claims from multiple providers, again, adding on to this administrative bloat and unnecessary costs in the system. And then two, from an economic perspective, if we increase the pool of providers, we can help put downward pressure on reimbursement negotiations, just having more providers available to help with covered lives. Next, this is something that has been talked about today, the use of medical care resources. What we find in the data is that most of these studies show that APRNs and physicians use an equal amount of medical services, and if anything, APRNs are actually a little bit lower. And I know there's a lot of studies to dispute this. I've referenced a couple here, including a literature review of 69 studies that looked at random control trials and things like that. But I think the point to make here is that opponents of this reform often say, well, there is going to be, with the perceived relative lack of training from APRNs to physicians, that they would order more tests, they'd have to cover their bases more. Well, that's just not what we see in the data, and I think it would be more prevalent if that was the case. And then what I'll talk about more in a minute here, but I think a lot of what this bill does is helps with the focus on primary and preventative care, and we can do a lot of beneficial things for the citizens of this state by focusing more on primary care, limiting trips to the ER, and better management of chronic diseases, and that all starts with primary care in this state. So now I wanted to touch on the rural healthcare aspect of this. Members of the committee, you don't need me to tell you the problems with primary care shortages in this state. This is a map from DHHS that shows both geographic and population-based HPSA areas. And then besides just what we know, national data shows that there's a decline in Americans with access to a primary care provider. And so that's a big problem, especially if we talk about preventative and primary care. But there's also been research that's been talked about. Full practice authority has been found to increase nurse practitioner employment in primary care and participation in Medicaid. And so that's a good thing for all of our rural counties. And as we've talked about today, there's a big need in rural areas where nurse practitioners have been shown in research to be more likely than their physician counterparts to go out to rural areas, so this can also help. And then from the Dr. Conover study, he estimated, based on his model, an increase of 1,700 additional APRNs in the state with full practice authority. And, this can go a long way to addressing almost all of the shortages in the state. Now, this is not to say that this is a silver bullet for all of rural health care problems in the state, but we deny these professionals the ability to at least attempt to make a difference if we don't grant them full practice authority, and we know the need is there. And then two, I really think it's important just to emphasize this provider-patient relationship, especially in our rural areas. If we can get more people regularly seeing a provider, get them more comfortable with the healthcare system, we can save a lot of money on the back end by avoiding a lot of these chronic illnesses or just basic preventative measures that we can address up front. Next, I wanted to talk about direct primary care briefly. For those of you who are not familiar, direct primary care operates like a gym membership. You pay a monthly premium or a monthly membership fee to the provider, and industry data puts this for your average adult at about $82. You get around-the-clock access to primary care, and the reason that these practices are able to keep costs so low is they don't deal with insurance. There's no third-party reimbursement. It's just you paying for medical services, and the legislators passed HB 471 not too long ago, which protects direct primary care practices from being subject to insurance regulations. So we have a very strong law that protects these practices. And if we were to grant nurse practitioners full practice authority, here's another low-cost way that nurse practitioners can serve North Carolina patients in a primary care setting. And this is sort of a niche market right now, but it's growing. As you can see, in 2014, there's 125 practices, and we're up to 1,500 across the country, and we're up to 76 here in North Carolina. And then also, there's been bipartisan federal proposed legislation that would allow DPC membership fees to be an eligible HSA expense. That has not happened yet, but I believe it will, and once that is, more Americans will have more options to pay for direct primary care. Two more points I wanted to leave you all with. The first, another part of this that we can think of in benefiting the economy is how this reform would benefit employers, especially for the 76% of employers that offer self-insured plans where they're bearing all the risk, paying claims out of pocket. If we have artificially inflated healthcare prices, like we've talked about, by limiting APRNs, well, that's money that businesses in North Carolina are paying that they wouldn't otherwise have to, and that leaves less money for wages and other benefits. So I think you can think of this too as a sort of a business reform, and we know how expensive family and individual premiums are for employees. And then next, retail health clinics are growing, and especially in the South and in more rural areas, we see retail health clinics growing. And these are often staffed by either a nurse practitioner or a physician's assistant. So again, in thinking of how we can adapt our workforce to the coming needs, granting nurses full practice authority, allow them to practice more independently in these retail health clinics. And I think the best thing about these is they're conveniently located, they're low cost, and they have transparent pricing. And this is an example of the market adapting. There's deficiencies in primary care, and the market has adapted to provide it at a low-cost service for those that don't have access otherwise. And this is an area where I think regulations would stand in the way of further growth of this industry. So just briefly, in conclusion, granting nurses full practice authority will lower healthcare costs and increase access around the state. I know we've talked a little about a few studies presented today, but in the course of my research and what I've seen, I haven't seen any evidence that shows allowing for full practice authority leads to overall negative health outcomes in a state. These supervision requirements threaten the ability of APRNs to practice, and what I mean by that is, and I think this was mentioned in an earlier presentation, but imagine if your profession was at the mercy of someone else that you have no control over, and at any time they could decide to pack up and leave, and you don't find another supervising physician. Again, that's care that we're directly taking away because of these supervision requirements. The reform could alleviate shortages and attract people in our state. I'm sure a lot of people in here, I've heard from people that would like to move to North Carolina that are APRNs, but because of the practice environment, they choose not to. So that's another economic miss there. And if we think about what businesses are spending on their employees for health coverage, this reform will be good for businesses and the economy. You know you're going to get this from the John Locke presenter, but there are no taxpayer costs associated with this reform, and I think that's one of the biggest things to remember as we talk about all of these reforms in the in this committee. So that's the end of my presentation, and I'd be happy to answer any questions.
Thank you, Jordan. Questions from the committee. Representative Baker, and we are behind schedule, so we do have to be quick.
Thank you, Madam Chair. I'm so sorry. Thank you. Thank you so much, Jordan. I appreciate your presentation, and I know we share a distinct love for data. So just a couple things. I'm trying to be brief, but in terms of outcomes, in September of 2020, the Journal of Internal Medicine showed that NPs and PAs with independent practice authority were more than 20 times more likely to overprescribe opioids than NPs or PAs in authority-restricted states. So in terms of outcome, very recent study that's concerning. Happy for you to address that. And then my other quick question is around the big study, the Hattiesburg Clinic in Mississippi. I will look up your study and compare those, but that's a model. And this study in Mississippi was an enclosed affordable care operation with 33,000 Medicare patients, and they had surprising, unexpected outcomes. 2/3 of their practitioners are non-physician practitioners, so they were fans of that model. And in having to review their costs because of their structure, like we're looking at going in our state with managed care taking over, it's a very similar model. And in looking at that, they expected that they were going to have to tell physicians to keep their costs down. In fact, it was the NPs, and it was because of the excess referrals, excess testing, and ER visits. And in fact, they found in that study that ER visits for patients who were not seen, whose primary care provider was not a physician, the ER visits were higher than for those patients who had no primary care provider at all. And this is a primary care clinic in a rural area of Mississippi. So I think it's a very similar model. So anyway, I would love to discuss that further.
I would love to. I'm not familiar with those, so once we get a chance, I'd love to talk to you about that. But I will say, you know, for a lot of these studies, there are limitations, and I think as a researcher in this capacity, we look for trends in the data, and just the overall trends and outcomes just don't show that. So that's the reason for it being in the presentation.
Representative Cunningham.
Thank you, Madam Chair. I'm just going to make a remark. I want to thank you so much for referencing that it's reform, it's regulatory reform. And I appreciate you putting the references in your document. And lastly, we put in place within the last several years on the prescribing opioids. So we have that in place as protection. So I still think we can't go back. We need to be moving forward with regulatory reform. Thank you, Madam Chair.
Thank you, Representative Cunningham. Thank you, Jordan, so much. We appreciate the information.
Yeah.
Next on our agenda is Karen Smith, and she is a medical doctor from a family physician from Rayford, North Carolina, Hogue County. Welcome, Ms. Smith, and she's going to give the case for physician supervision for advanced practice registered nurses. Thank you for being here.
Thank you, Chairs Kravick and Lambeth, members of the committee. I am Karen Smith, and I am a medical doctor, a family physician, and I have the privilege of practicing medicine in the independent practice in Rayford, North Carolina, Hogue County. I treat patients from ages from birth all the way to the end of life, and I love my work, and I consider it an honor to serve my patients. I've been invited to here to speak on behalf of the members of the North Carolina Medical Society, and I thank you for the invitation. My interest in medicine began as a child growing up in rural southern Maryland, and a love of science ran deep in my family. My father was a biochemist at the National Institutes of Health for 38 years, and my mother was also employed at the National Institute of Mental Health right down the road from the NIH. I had the honor of attending Duke University, where I earned my bachelor's degree in biology, and I earned my medical degree from Hahnemann University School of Medicine in Philadelphia. And then following medical school, I completed my residency right here in North Carolina at the Duke Fahey Family Medicine Residency Program in Fayetteville. I had many choices about where to practice, but I chose to practice in Rayford, because I thought that was the place where I could have most impact on most lives. I like what former Senator Bill Purcell, one of my mentors, used to say when asked why he chose to practice pediatrics at Laurinburg. That is where I was needed. Madam Chair, I have enjoyed the hearing today. It is interesting to hear the different points of views from some who treat patients and others from academia and advocacy groups. And I plan to share some studies and data that developed by the trusted sources that I recommend for your consideration as you contemplate the right healthcare policies for our state. I will offer my own personal experience and observations gained through the collaborating with PAs and nurse practitioners and physicians for over 30 years. First, I will offer some comments about the current requirement for supervision of advanced practice RNs and other providers. I typically refer to it as a collaboration because that is how it typically plays out. More often, we are in a collegial, professional exchange of information relationships that results in collaborative work designed to help the patient. And the education requirements for physicians and others in our healthcare system are an important consideration. I believe hands-on training of healthcare professionals matters. And the challenge of access to care, especially in rural North Carolina, what should work and what we have seen in other states. The cost of health care is another issue. The scope of practice changes, and it can impact it. There's data out there that can be utilized. And finally, we know the policy options that can improve access to health care, what we believe are worthy for your consideration. And we offer a list for you to consider. Let's see. And I think I may have gone too far, so let me go back a second. The North Carolina Medical Board has a position statement specifically setting clear expectations for physician supervision. And the Medical Society also has a policy statement providing guidance for supervising physicians. And we'll gladly provide that information. So how do we become a physician? So undergraduate was 4 years, medical school 4 years, residency 3 to 7 years, and in that residency, 80-hour work weeks, and I could tell you 30 years ago, it was a little bit more than that. And then we go through a very rigorous licensing process where the North Carolina Medical Board checks everything that we did, every test that we passed. Did we pass our licensing exam, step 1, step 2, step 3? They check it before we can practice in this state. So why, and then some of us decide to do fellowships, and I had the honor of doing that. But why is it so rigorous? What is it that we have discovered to prepare every medical student from every medical school in this country to have minimum competence to practice medicine, diagnose, treat disease, and prescribe medications for serious medical conditions? That's what it takes. So here we have physicians, comprehensive, hands-on, standardized and proven. We know that in our medical schools, and we've heard so much from our nurse practitioner colleagues. They too have limited hands-on. It's not quite as standardized. But then we have residency, 3 to 7 years. There's no residency in nurse practitioner education. And in clinical training, we spoke about hours, 10,000, 16,000 hours for physician training. And we see 500 to 720 hours for training for nurse practitioners. And we did hear some variation of that. But this is the typical that I'm presenting today. So every healthcare professional has a fundamental role to play. Physicians, based on their education and training, are uniquely qualified to work with our advanced practice registered nurses. But let's look at, in terms of the need for collaborative, physician-guided care teams. The advanced practice registered nurses are important members of the care team, and I can't overemphasize that. In the work that I do every day, I cannot overemphasize that. But patients want physician experts with the highest level of training, education, and experience to be by their side to deal with the unexpected, which our anesthesiology colleagues so clearly stated. For example, there was a national survey conducted by the American Medical Association, and that study found 95% of U.S. voters believe it is important for physicians to be involved in diagnosis and treatment decisions. 91% of U.S. voters believe a physician's education and training are vital for optimal care. And 3 out of 4 would wait longer and pay more to be treated by a physician. Now, my personal experience also affirms the need for collaborative, physician-guided care teams for optimal patient care. I have supervised and trained several nurse practitioners at varying stages of their careers, and I've observed disparities, not only in the education and the training among the nurse practitioner students, but also among the readiness for nurse practitioners with similar years of experience. It is important to note that an increasing number of NP programs are fully or partially online. There's no standardization for obtaining practical experience in clinical care, and many programs require the participants to find their own preceptors. And I have perceived a substantial variation in the nurse practitioner education. Now, when I'm working with the APR and student, I ask, what is the education? What is their experience? What is their skill set? And I have found, unfortunately, inconsistency across the board among education, training, and readiness for the NPs that I have trained and supervised. And I have seen this impact on their ability to assess a patient and communicate the patient's problems. I had a patient who came in 2 weeks ago, and I had a advanced practice nurse student, and patient came in, just wanted to know if she was pregnant. Previous pregnancy tests noted that they were always negative. That's all she wanted to do, and the nurse practitioner student came back and said, this patient wants to know if she's pregnant. I went in to communicate with the patient. The patient not only wanted to know if she was pregnant, but why. She can go to the drugstore and get a pregnancy test, but because she had bleeding complications in prior pregnancies. Her mother died of the same bleeding disorder. She had tuberculosis as a child. That was going to complicate her care during that pregnancy. It was a high-risk pregnancy. I had another story. 3-year-old came in. He was limping. And the nurse practitioner student it was a nurse practitioner at that time, said, we need an x-ray for this child. It might be a spiral fracture of the limb. But I watched the child walk, and he was limping, but dragging his leg like an adult who had a stroke. We didn't get an x-ray. We got a CT scan of the brain. The child had a tumor and unfortunately died of that mass. So it's situations like these that show patients will not receive the level of care they need unless they are being seen in a collaborative practice. And these experiences illustrate why team-based care and physician collaboration must remain critical components of optimal patient care. My experiences are not uncommon. These are the same experiences shared by my colleagues across the state, and I can say across the country, because I was on a call last night and heard the same situations. Now, we acknowledge there are no flawless healthcare practitioners, but we know what it takes to prepare intelligent people to be prepared to conduct differential diagnosis, and that training is medical school. So let's talk about the scope changes. Do they provide access? Do they not? Even in the states where certain practitioners practice independently, research shows that non-physicians have not changed their practice location, nor have they alleviated the shortage of problems in rural areas. For example, we've heard this study already quoted. The CMS Graduate Nurse Demonstration Project provided funding to 5 eligible hospitals, one of which sits in this room, and I believe I participated in the project that each participated with schools of nursing, community-based care settings, and other hospitals, and found that only 25% of the graduates went on to provide care in medically underserved communities like Hope County, which the vast majority of those providing the care, and they went to urban settings, and only 9% going on to work in rural areas and 2% in federally qualified health centers, which we are certainly looking forward to see functioning. And other studies also revealed that fewer nurse practitioners are providing primary care. For example, a study in the Oregon Center for Nursing found only 25% of nurse practitioners practice in primary care. Similar workforce studies in other states have revealed newly graduated nurse practitioners are more likely to enter specialty or subspecialty care rather than primary care, what I do every day for 30 years. So let's look at some of these studies. Now, proponents of scope of practice expansion suggest that scope expansions are necessary to expand access to care in rural areas. However, when we look at the actual practice locations of primary care physicians compared to nurse practitioners, we see that physicians and nurse practitioners tend to practice in the same area of the state, even in those states where nurse practitioners can practice without physician supervision or collaboration. The AMA mapped out the locations of primary care physicians and various non-physicians nationwide, looking at studies 2013, 2018, 2020. And what we saw was that regardless of the state scope of practice, nurse midwives, nurse anesthetists, nurse practitioners tend to practice in the same areas of the state. So despite claims to the contrary, nurse practitioners have not moved into rural areas even after legislators removed the physician supervision collaboration. And I'm going to go ahead and show some of our maps that we have looking at. Wyoming. While the number of nurse practitioners in the state has increased since they allowed independent practice, nurse practitioners have not moved into the rural areas of the state. Oregon, likewise, the nurse practitioners have not moved to rural areas of the state and continue to practice in the same areas of the state as physicians. But then we look at our colleagues over in West Virginia. Now, West Virginia enacted legislation in the year 2017 that allows nurse practitioners to diagnose and treat patients without physician involvement. They're still required to have a collaborative relationship for the prescriptive practice with physicians for 3 years. And while there was an increase in the overall number of nurse practitioners in the state, they continued to practice in the same areas of the state as the physicians. But what about Georgia? Okay, in Georgia, nurse practitioners practice pursuant to a protocol agreement with physician supervision and delegation, supporting a physician-led team-based care approach, similar to what I do. Georgia has seen a tremendous growth in the number of nurse practitioners in the state. When we look at the year 2013, there were 4,275. We're now looking at the year 2020 and above, where it was 10,291. Nurse practitioners are located across the state in rural and urban areas, and this demonstrates that the changes in nurse practitioner scope of practice laws are not a primary reason for growth of nurse practitioners in a state or where they practice. Repealing the presence of supervision has not impacted rural areas. What about home, North Carolina? So based on these maps, we see that the number of nurse practitioners in the state has more than doubled between the years 2013 and 2020, where it went from 4,523 to 9,121. Very similar to what we were seeing in Georgia. This rapid growth suggests we don't have an issue recruiting nurse practitioners to work in North Carolina. But let's talk about our cost. X-ray ordering. And let me say this, because I teach this to our students, because I learned it from my mentors. X-rays and laboratory do not make the diagnosis. They support the diagnosis. It's the cognitive ability of the individual physician and practitioner, and we use these studies to support the diagnosis. Now, X-ray ordering increased 441% among non-physicians. Non-physicians needed more biopsies. Patients who were 15% were more likely to receive an antibiotic from a non-physician, antibiotic stewardship. 6.3% of the nurse practitioners prescribed opioids to over half of their patients. And I do medication-assisted treatment for substance use disorders in our community. And this is a concern. Now let's talk about the Hattiesburg Clinic. And I'm not going to break it down because Representative Baker did a wonderful job doing that, but I just want to highlight some things. Now, Hattiesburg Clinic I appreciate because it kind of reminds me of Hope County a little bit, and when I talk to my colleagues from down in Mississippi. Now, what they did, this was a CMS cost data study, by the way. And also, some may have noted that I'd spend work with CMS as a quality physician program championing where we are going with value-based payment models. So this data matters. In a recent study, 2017 to 2019, CMS cost data from the Hattiesburg Clinic in Mississippi found primary care provided by non-physician and PAs and their own panels. They had their own panels was more expensive than care delivered by the physicians. Now, Hattiesburg Clinic is an ACO, and I'm also a local medical director for an accountable care organization here in this state. And the ACO actually rewards the providers for being more efficient. And the goal for this study was to actually allow APPs to have their own panel of patients with less complexity. And the clinic believed in doing so that they could provide similar quality of care, keep costs stable, and meet patient expectations. This was not the case. And what they found from the study, just some key factors, that the physicians did perform 9 out of 10 better on the quality measures. The cost in the APP primary care panel was $43 higher per member per month compared to the physician primary care panels. And then they did a risk adjustment for patient complexity. And when they did that, the difference jumped up to $119 per member per month. Utilization, we've already spoke about. So we see that the Hattiesburg study did bring out more information. And then we talk about the patient experience, and I've truly appreciated the comments that have been shared. Patient ratings were similar between the physicians and the advanced practice providers, but when they looked at the overall score, the physicians had higher ratings over 6 domains. So moving forward, the Hattiesburg Clinic, they indicated that it will continue to utilize the APPs as an integral and important member of the care team, but they will no longer have their own panel. It will be integrated in a collaborative manner. So what are our solutions? Independent practice for advanced practice registered nurses is not the solution for rural health care access. The patients our care for are not well served by NPs practicing independently and without a team, but they are well served when they are working in a collaborative model. The SAVE Act cannot guarantee increased access in rural and underserved areas. Instead, we encourage the committee to consider solutions designed to address the root causes of the healthcare professional shortages in rural areas. And we know of some policies that exist. Medicaid expansion, increase the number of compensated care and rural practices available to rural providers, loan repayment. We know that that works. The Office of Rural Health, the reason why I'm in Hope County and still there 30 years, is that they offer incentive programs for qualifying practitioners, providing primary care in those rural settings. The North Carolina Medical Society Foundation's Community Practitioner Program, a reason why I'm there, also provides funds to offset. And then we have tools such as telehealth, which we learned during the pandemic. Telehealth can be a powerful tool to provide quality health care locally and at lower costs. And this directly benefits our rural patients. And so we see that the legislation requiring health benefit plan coverage for the delivery of health care services through telehealth would ensure patients in rural areas continue to receive improved care. I thank you for your attention. And members of the committee, I appreciate your service to the state. It's not easy to balance all of the interests that that you have. That's a challenging job as a legislator. And when making decisions about entrusting the health and safety of your fellow citizens, your constituents, even family members, err on the side of safety and choose for others what you would choose for yourselves. Put patient safety first. I thank you and appreciate any questions.
Thank you, Dr. Smith. Representative Cunningham.
Thank you so much, Madam Chair. Dr. Smith, thank you for giving us your viewpoint. But for a long time, my voice wasn't quite available to me. But today it is. And I'm going to make this comment. And I'm going to be very comfortable making it. When we have professionals to come in to our committee and present to us, it should not be to degenerate another profession. We are all human beings that function in society in each profession, not just healthcare. I love doctors. I've worked with doctors 30-some years, but I've also worked with nurse practitioners, also certified nurse anesthetist. I have respect for each profession. This is a regulatory reform. I'm saying this because when I looked around the room, yes, I'm on this committee. I am African American, and when I looked around the room, I didn't see that many of me in here. But my voice at this table is to increase healthcare access and to collaborate and move our state forward in regulatory reform. We should never, never lessen a person or human being in their profession. We are not perfect. They are no professional perfectionists. Thank you, Madam Chair.
Thank you, Representative Cunningham. Senator Heiss.
Thank you, Madam Chairman. One of the challenges I just wanted to ask about for most of these clinic reviews, more than experiments that are kind of out there, you don't have a patient come in and roll a dice or somehow randomly assign them to today you're going to see a physician, tomorrow you're going to see a nurse practitioner. You review everyone saw by a nurse practitioner, everyone saw by a doctor, and make these comparisons over the time. But when health care is provided with physicians and nurse practitioners, in most of the clinics that I have seen, the nurse practitioners serve as more for incoming patients as this front line type of thing. When someone comes in with an arm that appears to be hurt or injured, they are more likely to send them to a nurse practitioner versus someone who comes with something presenting themselves more serious. They want to get them to the physician. does it not make sense that conditions that would require x-rays, an initial screening that looked for skin cancer, something that required an antibiotic, so if you've had this going on all over the community, or a pain procedure, someone comes in with pain and needs something to relieve the pain, is it not innate that that would, in these practices, be more seen by someone who is a nurse practitioner than someone who is referred to the physician to see that? So to come back and say, x-rays are 440% more likely to be ordered among nurse practitioners. Well, that's fine to review the cases, but if you're sending everyone with an injured arm to a nurse practitioner in that process, it doesn't tell you what this information claims to be saying, that nurse practitioners in the same circumstances are more likely to order an x-ray. It merely speaks to the assignment of cases.
Dr. Smith.
Thank you so much. And may I please say that I have been blessed over the course of time to work side by side with physician's assistants. And even in my first time in Hope County, the first 3 PAs that I worked with came from Fort Bragg. They served in Vietnam. They taught me a lot. And I respected them. I needed them. I definitely needed them when the snake bite came in the door. And then also for our nurse practitioners who worked in our setting, the one that I supervised at the health department as part of that arrangement. We need our nurse practitioners. We need our PAs. But one thing that we do before we even begin the practice is we sit down and we review the education, the experience, the skill set, and the comfort level. And we make sure that we have the communication that allows us to be engaged and work collaboratively with each other so that we don't increase the cost of care, so that we don't have excessive x-rays and radiology lab tests done. We work in a collaborative manner, and I have appreciated through so many years the collaborative work that we have done. And I further appreciate the collaborations that's going to land us in a solution together that will allow increased access to care. So I hope I have answered the question by noting is the education, the experience, and the skills, and the flexibility of our current rules that allows us to create that practice which serves the patient.
Thank you, Dr. Smith. Members, are there any other questions, very quickly, because we have run over time. Thank you, Dr. Smith. We appreciate the presentation. Next, we're going to hear from Winifred Quinn, PhD, and she is the Director, Advocacy and Consumer Affairs for the Center to Champion Nursing in America, AARP Public Policy Institute, and going to discuss expanding access and lowering costs for seniors through full practice authority. Thank you. Welcome.
Thank you so much, Co-Chairs Krawick and Lambeth, for having me here today, and to speak to all of you on this very important topic of full practice authority for advanced practice registered nurses, otherwise known as APRNs. North Carolina is rapidly growing in terms of its population, especially in terms of its population of people 65 and older. By the year 2030, 1 in 5 North Carolinians will be that age, and which means that there will be more 65-year-old people and older, more than there will be 18 and younger. So where the demographics of this state is changing, it will be really important for North Carolina to take a look at the healthcare delivery of the state as well. On behalf of AARP's 1.1 million members in the state and nearly 38 million members across the country, I am more than honored to be here today. AARP has been working very hard for more than a decade on this issue at the state and the national levels because our members need and want improved access to care and choice of healthcare professionals. Access to affordable health care quality is a top priority for AARP and our members. On behalf of patients and consumers, I would like to start with a few points about what proposals like the SAVE Act Care are and are not. They are about access to care, patient choice, and making the most of our scarce healthcare resources. They are not about a turf war between nurses and physicians. They are about patients and families. By removing the bureaucratic mandate for APRNs to be supervised by another clinical sector and be able to provide the clinical care which they are experts in, full practice authority bills are about consumers having direct access to all health professionals. The current mandates and their unnecessary paperwork are red tape that occupies too much time of all APRNs as well as their contracted physicians. I want to underscore this point. This unnecessary paperwork prevents patients from having better access to physicians as well as APRNs. We strongly support physicians and appreciate all of the hard work and the great care that you provide and they provide. We would like less of their time spent on paperwork and more of their time spent with healthcare consumers. By removing this bureaucratic red tape, patients have direct access to all APRNs in the state. AARP deeply values the care that all 4 sets of APRNs provide. Nurse practitioners are the most prevalent. While some are in specialty areas, most are in primary care, and a good proportion of nurse practitioners are gerontological experts. They are also more likely to provide care to people in underserved communities, including rural. Certified registered nurse anesthetists provide very important services for older adults, especially in rural areas. Rather than traveling far distances or delaying necessary care, older adults with access to certified registered nurse anesthetists would have better health outcomes. And their families would also be able to direct more of their time to work and rather than taking time off of work to transport their older loved ones for greater distances of care. Many people may not see a connection between the needs of the 50-plus and certified nurse midwives, but we do. Certified nurse midwives are often the main primary care provider for all people in rural communities. Also, women 50 and older continue to have women's health care needs. Therefore, certified nurse midwives are excellent women's health care clinicians as well as primary care providers. And finally, there are the clinical nurse specialists, perhaps the most unsung heroes among all APRNs. They also provide very important services for older adults, especially when it comes to chronic care management. They are the most highly skilled clinicians for people with multiple chronic conditions. When people with chronic conditions lack the care when and where they need it, they are more likely to be hospitalized and unnecessarily rehospitalized within 30 days of discharge. Clinical nurse specialists are the top clinicians who improve the quality of life for people with chronic conditions, and they play a very important role in containing healthcare costs. To refer to my own experiences as a family caregiver, which is, I bet, something that most of you can relate to, the physicians provided great clinical care. Most of the efforts, but the efforts it took to make sure that my parents were getting the care and services at home when they needed them was nearly impossible to manage as a family caregiver. And in fact, my parents were unnecessarily rehospitalized on numerous occasions because of that lack of integration between the care and the services that they needed. Clinical nurse specialists could have been there, and they can really help solve so many problems for the patients and the families, as can all of the other APRN groups I just described. Above all, bills like the SAVE Act are about health care quality and access. Patients and families know this, and the evidence is there over many years and many studies. The quality of care provided by APRNs is no less than that of physicians, and are often excellent complements in the clinical care provided by physicians and other providers. We often hear unfounded concerns about the quality of care provided by APRNs, and I want to be very clear. AARP would not be supporting full practice authority for APRNs if we thought that there was a problem with the quality of care they provided. We just wouldn't do so, and we fully support APRN provided care. So now I would like to review, again from the consumer perspective, the evidence in favor of APRN full practice authority and patients' direct access to care. AARP relies upon a mountain of evidence that shows how much consumers benefit from direct access to APRNs. And some of these meta-studies I'm going to review have been mentioned before several times today. So first, I'll review some evidence of quality. There is overwhelming evidence based on rigorous research over many years demonstrating that quality of services provided by APRNs is equal to or higher than, in some cases, especially around patient satisfaction, than that of other health professionals. Arguments to the contrary do not hold up to decades of real-world and research evidence. Last year, a team of researchers led by Dr. Yang at Towson University of Maryland produced a summary of quality-related studies over the past 20 years. Among these findings, these stand out as they pertain to consumers. Most studies found no difference between the quality of care provided by nurse practitioners and physicians. One study found no difference in the quality of care for Medicare beneficiaries being cared for by nurse practitioners in full practice authority states, and those where nurse practitioners are required to contract with physicians. In other words, physician supervision had no impact on quality of care. And as a consumer, I would like to point out that with 2 clinicians involved in the provision of care, both clinicians are being paid. And that distribution of the payment, that source of payment, ends up costing the healthcare system more, often absorbed by the consumer. Other studies did find some significant differences that need to be underscored. The healthcare economist Spetz and her team in 2013 reported a lower number of hospitalizations, less emergency department use, and a lower number of chronic condition indicators in states with full practice authority compared to those states without it. Trusinski and Udalova also found higher patient satisfaction for office visits in full practice authority states compared to states with restricted practice authority. There are other studies that focus on health status of a specific care domain. Researchers reported significant improvement in self-reported mental health status and a decrease in mental health needs, and opioid-related mortality rates in states with nurse practitioner prescriptive authority. Smith, Gagan, and their team found 2-fold higher odds of being diagnosed with late-stage cervical cancer in states where consumers lack direct access to APRNs compared to those with full practice authority. So I need to underscore this. If a woman is living in a state that does not have where the woman doesn't have direct access to APRNs, they are more likely to be diagnosed with cervical cancer later in their cancer than they are earlier, where their care would be better and outcome would be more likely to be better. The prestigious National Academy of Medicine, after its lengthy and rigorous review of the evidence, recommended that states remove outdated barriers preventing APRNs from practicing to the full extent of their education and training. That report came out last year, and it was a follow-up to its precursor from the Institute of Medicine, which recommended the same in 2011, which our anesthetist referred to earlier. In its 2012 review of evidence of the quality of care provided by nurse practitioners, the National Governors Association found that nurse practitioners provided at least equal to quality of care as compared to physicians in studies measuring patient satisfaction, time spent with patients, prescribing accuracy, the provision of preventive education, and health outcomes. A meta-analysis of 11 research trials comparing pregnancy and birthing care led by certified nurse midwives in traditional care models concluded that certified nurse midwifery care is associated with reduced adverse health outcomes and shorter newborn hospital stays without any reduction in maternal or child health. And as far back as 2003, a 22-case control study of Medicare beneficiaries found no difference in outcomes between certified registered nurse anesthetists and anesthesiologists working alone or as part of a care team. Benjamin McMichael, a law professor at the University of Alabama, published a 2021 analysis regarding opioid prescribing. He found that of the approximately 1.5 billion individual opioid prescriptions between 2011 and 2018 across all nurse practitioners and physicians, full practice authority for nurse practitioners was associated with a statistically significant decline of between 2% and 7% in total annual opioids prescribed to all patients. So now I would like to review evidence of improved access. 4 published research papers that focused on access to care reported that in states where nurse practitioners have full practice authority, nurse practitioner supply is higher, nurse practitioner supply is linked to greater care access, and there were fewer avoidable hospitalizations and rehospitalizations and lower rates of nursing home resident hospitalizations. A 2015 study found that in states with full practice authority for nurse practitioners, Medicaid patients were more likely to get new patient appointments and experience fewer office visit costs. The same study that included a survey of approximately 1,000 primary care physicians and nurse practitioners found that nurse practitioners were more likely than physicians to practice in urban and rural areas and more likely to treat Medicaid recipients. A 2016 study found that states with laws allowing APRNs to practice to the full extent of their education and training had 40% more nurse practitioners per capita, and people living in those states had significantly greater access to primary care than in restricted care states. Bearing this out, one example of the impact of the passage of full practice authority on the number of APRNs practicing in a state come from Nevada. Nevada was referenced earlier, citing a smaller time period. Nevadans saw a 68% increase in the number of APRNs practicing in their state over a 3.5-year period between June of 2013, when the legislature, or when the governor first signed their bill, and in January 2017. In 2017, the Veterans Administration authorized its health system to enable APRNs caring for our veterans to practice to the full extent of their education and training. All the APRNs except for certified registered nurse anesthetists. All VA facilities are now operating under these rules. A study published last year found that the removal of practice barriers had reduced wait times for veterans to get medical appointments. Veterans enjoyed more timely appointments for primary care, specialty care, and mental health care in those VA facilities with APRN full practice authority, compared to the facilities that had not yet implemented the new reforms. A 2018 study published by the American Enterprise Institute found that geographic access to primary care was significantly higher in states that did not restrict nurse practitioners' scope of practice compared to those that did. 63% of people living in non-restrictive states had geographic access to counties with a high capacity of primary care clinicians, compared to 34% of people living in states that restrict nurse practitioners' scope of practice. Results that showed that states with restricted nurse practitioner scope of practice had 40% fewer nurse practitioners compared to those without. These findings suggest that lifting scope of practice restrictions on nurse practitioners would over time increase access to primary care, particularly in rural areas. Returning to Yang's 2020 meta-analysis of a large number of research studies on the impact of full practice authority for nurse practitioners concludes with, quote, advocates for full practice authority argue that removing nurse practitioner practice restrictions could improve access to primary care. Our review found strong uniform evidence to support this argument, indicating that full practice authority was positively associated with access to care and health service utilization, especially in primary care settings, and without increasing potential patient safety issues, close quote. So, for example, overprescribing medications with high abuse potential, such as opioids. Same study, Yang's meta-analysis, also has numerous studies regarding cost. Returning to Spetz, the health economist, she and her team found that patients who visited retail clinics in full practice authority states had significantly lower total non-inpatient and prescriptive payments compared to those in restricted states. Further, nurse practitioners in states with full or partial prescriptive authority were associated with significantly more prescriptions filled and higher total and prescription payments relative to more restrictive states. NEPR found that restrictive practice authority was associated with higher direct and indirect costs of diabetes management. Kleiner and their team found specifically focused on the price of well-child visits and reported a significant decrease in the price of those visits in states recognizing nurse practitioner prescriptive authority. In contrast, Stange's 2014 study on a national sample of office visits reported no significant difference in total charges according to the level of state nurse practitioner regulations. In other words, nurse practitioners' full practice authority didn't drive up costs. Two other studies examined the change in total costs of Medicaid claims per beneficiaries using the same years of data. The economist Timmons found no significant change, where Pogosian and their team reported a significant decrease in the total costs of Medicaid claims per beneficiaries. Cost citations outside of Yang's meta-analysis also includes a 2018 American Enterprise Institute study that found that across 5 measures, the cost of primary care provided by nurse practitioners ranged between 11% and 29% less than the cost of primary care by physicians. The gap was most pronounced for evaluation and management services, composing 80% of claims that primary care physicians and primary care nurse practitioners bill to Medicare. Beneficiaries treated by primary care nurse practitioners who receive such services cost Medicare 29% less than beneficiaries who received their primary care from primary care physicians. The large differences in cost between primary care nurse practitioners and primary care physicians persisted even after taking into account that Medicare pays nurse practitioners at 85% the rate of physicians for the same services. In other words, the full deployment of advanced practice registered nurses doesn't only make sense, it saves dollars. In 2015, Duke University economists that have been cited earlier today conducted an analysis of the economic benefits that the state of North Carolina would experience if you were to remove the red tape that prevents patients from having direct access to APRNs. And they found that APRNs would ease the shortage of primary care providers in North Carolina, could provide at least $433 million in savings to the healthcare system in your state, and would also create at least 3,800 new jobs, generating the tax revenue of more than $20 million, and this is what Jordan was referring to earlier. Other benefits of ensuring that consumers have direct access to APRNs include caregiver productivity. I referenced this earlier. In other words, family caregivers wouldn't have to take so much time off of work to transport their older loved ones to clinical care or to provide direct care themselves. It also addresses the aging population, which I pointed out in North Carolina will be significantly growing within the next 8 years. And that's one of the key factors where people choose to retire is access to health care. It also aligns with care that North Carolina active duty military and their families and veterans already have. So that is a review of the studies pertaining to APRNs and to consumers and APRN's full practice authority, specifically about quality, access to care, and cost. And just to wrap up, I want to point out that when opponents of legislation like the SAVE Act raise fears of what it would mean for patients, please consider this. 24 states, some as long as 30 years or longer, have been operating under similar legislation. No state that has passed legislation like this has ever gone back and repealed it, and in fact, it's been the opposite. States have continued to remove further barriers to care. And most recently, 2 states, Massachusetts and Delaware, eased these barriers during the pandemic, have removed them permanently, which was cited earlier. So, as I mentioned in the beginning, it's smart to do things differently to help people 65 and older live the best lives possible. And actually, when doing so, you're not only improving the quality of life for people 65 and older, you're improving the quality of care and of life for other populations. So, for example, when you improve sidewalks and make them more walkable for people in wheelchairs. You're also making them better for mothers who are pushing strollers. And the same could be said for healthcare. When you're improving the policies that will allow consumers to have direct access to care, you're not only helping people 65 and older, you're also helping mothers and babies. So thank you again for having me. I'm happy to take any questions, including about the Medicare graduate nursing education study. I was one of the designers of that demonstration, and I'm very familiar with the report to Congress.
Thank you, Dr. Quinn. First question, Senator Heiss. No. Senator Corbin.
Thank you, Madam Chairman. Thank you for your presentation, and thanks to everybody who's presented today, the physicians that are here and those advocating on behalf of nurse practitioners. It's very obvious that everybody is very passionate about their profession. And I agree with Representative Cunningham that you should be valued in what you do. You obviously believe in what you do and your associations and so on and so forth. Madam Chairman, there's a couple of things in my mind we need to get some clarity. I think we all understand the difference in training levels of physicians and nurse practitioners. We all get that and understand that. To me, there's a couple of issues that are kind of paramount. One, I think we've heard some differing opinions, and I think they're sincere opinions about access to care or not, and cost. Less with physician supervision and less without it. We've heard both. And I think we need that. To me, that's kind of paramount in moving forward with or without the SAVE Act, is whether it's going to save money or not, and whether it's going to provide better access to care or not. So that's just a statement. Second is a question about supervision and what supervision means. I guess I could direct this question to our presenter. In these agreements, does it require the physician to collaborate with the nurse practitioner on a case-by-case basis?
So I'm not specific, I don't know the specific answer to North Carolina's law pertaining to how much the physician needs to be engaged in the provision of care when APRNs have contracts with physicians. But we view those, I mean, what I've shared today is not my opinion. It's decades of research, and it has said that those contracts are unnecessary, and we view them as red tape and bureaucracy that get in the way of patient care.
And follow up, Madam Chairman.
Follow up.
I think we need the answer to that. To me, that's kind of important to know what supervision is. Just for example, and I'll stop with this, going back to Dr. Cronin's presentation, which he gave the answer about what supervision meant to him, and I appreciate that. A very specific answer, and I know that was specific to his particular practice. I was thinking about one of the presentations mentioned showed Erlanger Hospital, which is in Murphy. There is no anesthesiologist there. There's a nurse practitioner or nurse anesthetist. Sorry, I have trouble with that word. So what does supervision mean? I looked up anesthesiologist for Murphy, and it lists one, but they're actually at Pardee Hospital in Hendersonville, which is 2 hours away.
Right.
So does that person collaborate on a case-by-case basis? Do they drive to Murphy 2 hours for? I think the answer is no, but I need some clarity.
Right. From what I understand, most of these contracts to be is that the physicians need to review a certain amount of cases of the advanced practice registered nurses over a course of time, and that they don't necessarily meet those patients. They've never seen the patients. They're reviewing a portion of the charts, the medical records kept by the APRNs. So I don't know how much quality. My personal opinion is that doesn't sound like it's a really good quality check, and that's what the data show.
Follow up very quickly.
Follow up.
And I'm getting to, I guess, the Sam Walton question of value added. What is the value added of having the supervision? If the value added is there, then we need to recognize that. And if it's not, we need to recognize that. So
I agree with you.
My question is, what is supervision and what does it mean to that patient? Is it a case-by-case basis? Is it a supervision from afar? Looking at 1 out of 10 cases, I don't know the answer to that.
Right, so. And I don't, it might be a good question for the Board of Nursing.
Or I'm thinking Dr. Cuomo Ramos, would you know the answer to that question?
Yes, ma'am.
You're recognized.
Sure, I'm happy also to have the Board of Nursing answer, but let me see, I think it's a great question, Senator Corbin. Couple of things, a lot of what I hear as being the argument is that we are stating that it's important to practice at the highest level of education, license, and competencies, those three things being together. I think that there are models where providers, different kinds of providers, work together, and there is really a reciprocal lifelong learning. I think that this notion that somehow we're not continuously developing our skills, our competencies, our knowledge is actually false. What I understand the actual supervision to mean in North Carolina is that it's a document that is signed. That doesn't mean that the physician and the nurse practitioner are co-located in the same place. They can be geographically apart from one another. It's a chart review that occurs, and there may be times when there's a review of cases, but it's not the case that they are sort of working hand in hand at all times with the patients. That's happening oftentimes through sort of the education experience where students are being precepted, and not always by a physician, but by somebody who is competent in care. And again, I think that there was sort of a lot of conflicting information today. My suggestion would be to look at I think Jordan captured this well, to look at the overall trends in the research, to look at the strength of the research, to look at the bodies that are objective and that are independent, that have been tasked with advancing recommendations. And, I think when you do that, you see that the care outcomes are comparable and that it actually does save costs. Last comment, I stated this during the time that I was speaking. The U.S. has the most expensive healthcare delivery system in the world of any developed country, and the worst outcomes in terms of mortality and morbidity. I think if we all are honest, we need to say that something's got to shift. And honestly, at the forefront of that has been the status quo, the way that things have been. We need to move to something different that will ensure health equity and improve outcomes.
Thank you, sir.
Thank you, Madam Chairman.
Thank you. And thank you very much, Dr. Quinn. We appreciate your information. And that was our final presenter, but I'm sorry, Representative Cunningham has a question. I'm sorry, I didn't see your.
Thank you, Madam Chair. And I'm not sure if Dr. Quinn can answer this, but we heard you speak on the lower recidivism rates in this rehospitalizations, and we see that happen a lot in the senior population or people at home. Can we pull some data? I don't know who needs to do it, to see the impact on Medicare cost savings, the impact on Medicaid cost savings, as well as hospital cost savings in that area. I would like to see some of that data if we can pull it and see what we can see there. Thank you so much, Madam Chair.
Thank you, Representative Cunningham. Thank you again, Doctor. And I want to add one thing to Senator Corbin's question. A nurse recently told me, now this is one story, one nurse. Her supervising physician lives in Tennessee. He's still licensed in North Carolina. He flies in, according to her, every 6 months and signs her authorization, and she pays him $15,000 a year, and she doesn't ever see him except that one time every 6 months. One story from one nurse who lives in my district. So I just wanted to share that because you were asking those questions. Having exhausted our agenda, thank you all presenters so much. We appreciate it. We are adjourned.